Okay. Oh, can you hear me?
Yes.
Okay, great. All right, so let's see, Representative Gail Armstrong?
She is here. She just stepped away.
Yeah.
Yeah.
Okay, I'll mark her here. Representative Joanne Ferrari?
Present.
Okay, Greg Fulfer? Representative Wanda Johnson? Senator Bill O'Neill? Senator Purtle? Representative Armstrong? And
I'm here.
Okay.
So we have four voting members present. One more will have a quorum. Now let's go ahead and do the introductions. I'm trying to see how we might do this most expeditiously. I'll just call a name out and then you introduce yourself, please. Okay, Representative Christine Trujillo.
Yes, good morning. I am Representative Christine Trujillo, and I represent House District 25 in the middle of Albuquerque.
Thank you, Representative. Good morning. Representative Ferrari.
Good morning, Mr. Chair. I'm Representative Joanne Ferrari from House District 37 in Las Cruces, and it's a beautiful morning down here. Thank you.
Great, good. Representative Bash.
Yes, good morning. I'm Representative Karen Bash from House District 68 here in Northwest Albuquerque.
Good to see you this morning, Representative. Representative Thompson.
Good morning, Mr. Chair and friends. I'm Representative Liz Thompson, House District 24 in the Northeast Heights of Albuquerque.
And are you coming to us from Baja California or Cancun this morning?
Hawaii, actually.
Oh, Hawaii, okay.
Yeah.
Nice.
Actually, if I'm dreaming, I'll just say Tahiti. I'm in Tahiti.
Tahiti, great, good. Representative Micaela Lara Cadena.
Good morning, Mr. Chair and members. Thank you. I am honored to serve New Mexico's House District 33 here in Doña Ana County. I am in Mesilla and virtually participating here where my family's been for generations, but the district includes also lots of Las Cruces. I just wanted to note really quick, Mr. Chair, I love to see your faces. We don't quite have sufficient access for myself to be on video and for my children to participate in their virtual learning. I, like so many New Mexicans, don't have what it takes. So we are always passing the baton about like who needs to be on and who can't. And so of course I'm working to prioritize their education. Even in Mesilla, outside the second biggest city in New Mexico, my internet comes through a phone line. I don't have fiber optics, I don't have broadband, I don't have satellite. So it certainly reminds me that in spite of all the ways that we have privilege and resource in our family, it's a stretch to be learning like this. So just that shout out to New Mexicans and parents that are trying to make it happen every day. So I will likely remain off video for most of the day until my girls have their school breaks and other things. But I'll be listening either this way or potentially through just the phone. But wonderful to be in this conversation today. And thank you.
Thank you, Representative, and thanks for sharing that information with us. That's very helpful. Senator Rodriguez.
Good morning, Mr. Chairman. I'm Senator Nancy Rodriguez from Santa Fe, the county seat, the place that hosts you all the time for legislative sessions and other committees. And we want you to come back, not only virtual, but in person. Good morning to everyone. I represent District 24.
Great. Thank you, Senator. Representative Patricia Roybal Caballero.
Good morning. Thank you, Mr. Chair. Good morning, members of the committee, and good morning, all of the audience listening. My name is Patricia Roybal Caballero, and I represent House District 13, which is the far southwest quadrant of Albuquerque. And also, please note that even though we're in Albuquerque and a large urban area, pockets of our area, the southwest quadrant in particular, we lose bandwidth. For some reason, we do not get the same amount of bandwidth as everybody else. It's beyond me. So there have been several times throughout these meetings where I get the message that because of low bandwidth, I'm going to blank out. So that also raises the same concerns that Representative Cadena raised. And so we really have our hands full doing virtual right now. So I appreciate being here and I look forward to our conversations today. Thank you, Mr. Chair.
Thank you, Representative. Then we have Representative Tara Lujan.
Morning, Mr. Chair and members. Tara Lujan, State House Representative for District 48 in County of Santa Fe. A very diverse district. I go from the east side of the county all the way to the south side of the county. Happy to be here with everybody. Look forward to some great conversations and look forward to celebrating our Szobra night tonight for all those who don't know. So it's going to be virtual. So if you all want to join in, you can pick it up online. And we, like Senator Rodriguez says, we're always happy to host you here in Santa Fe. And join us this evening if you can. Thank you. Have a wonderful day.
Great, thank you. And I noticed yesterday you were introduced as the newest state representative, but I think you lost that distinction this week when, yeah, so now you're this, you already have seniority over one other member, and it doesn't take long to rise to the top of the heap here in the legislature.
Thank you, sir. That's true.
That's right. Representative Armstrong.
Thank you, Mr. Chair, and welcome to everyone. I'm Representative Debbie Armstrong, and I represent District 17, which is the middle of the North Valley. And just a shout out to all my, and thank you to Representative Cadena. This is indeed hard, and as one of the people who keeps pushing for virtual options, I realize it's not easy. It's not even easy when you even have connections, but I really appreciate all that you have to go through, and anyone that's trying to school their kids at the same time, and sharing computer time and all that. This is none of it's easy. So, but I appreciate everyone being here, and I look forward to today's conversation. Thank you.
Great. Thank you, Representative. And of course, Representative Armstrong is the co-chairman of this committee. Did I miss any other legislators who were here? Did somebody come in since we started? And if so, just go ahead and chime in and introduce yourself. Yes.
Senator Michael Padilla.
Oh, great. Welcome, Senator. You want to introduce yourself?
Thank you, Mr. Chairman and members. Senator Michael Padilla. I represent the southwest quadrant of Bernalillo County, about 85 or 90% of it. My second or so, well, maybe this is now my third or fourth year on this committee. And I had never been a member, and I've learned so much, and I really appreciate the valuable input everybody brings. Thank you, Mr. Chairman.
Great, and welcome this morning, Senator. Go ahead, Senator Stefanik.
Thank you, Mr. Chair and Madam Chair. This is Senator Liz. And not only am I on mute, I'm joined also with my cat and my dog today.
Great. And you were just breaking up a little bit, which brings up something I hope Senator Padilla, who's been the great advocate for broadband, heard Representative Cadena's comments about Mesilla, just outside the second largest city in the state, having very poor access to broadband. So I think a lot of us are going to be dealing with that. And then let's have the staff introduce themselves. Why don't we start with you, Andy?
Hi, everybody. My name is Andrea Lazaro, and I staff this committee at this time of year. And throughout the year, I draft bills for them. And I'm happy to be here and hope that we have a good meeting. It seems to be going nice and smooth so far. Thank you.
And Nancy Martinez, you want to introduce yourself?
Hi, can you guys hear me?
Yes.
Hi, I'm Nancy Martinez, Legislative Council Service, Reacher's Assistant, and your host.
And are there any other Legislative Council staff here?
Tom should be on. I don't know if Tom wants to introduce himself.
Tom Krika, yes, please.
Yeah, this is Tom Krishka, LCS.
Great. Well, welcome everyone. I'm State Senator Jerry Ortiz-Pino, and it's my turn this summer to be the lead chair of the co-chairs for this committee. I represent Senate District 12, downtown Albuquerque. We actually enjoy very good broadband access here. I've got 3 granddaughters living with us, all of whom are doing their schoolwork today on their own Chromebooks all over this house. And I'm on, and so far, no problems. Senate District 12 includes the UNM campus, downtown Albuquerque, and the older historic neighborhoods around downtown. And with that, I think we're ready to move ahead. We have a very busy agenda today. We're going to start off with, where am I? We're going to start off with presentation on new developments in delivering medical assistance programs and services during the COVID-19 era, the pandemic era. And we've got with us Nicole Como, the Director of Medical Assistance for HSD, and Dr. Scrace, the Secretary of the Human Services Department. So whoever is going to kick it off, we welcome you, and we'll get started.
Thank you very much, Mr. Chair, members of the committee. It's great to be back. I want to say make a couple comments by way of thanking this committee. One, for all the time you're giving us. We got to present on everything but Medicaid last time and went through income support, the SNAP program, cash assistance programs, many of the programs we offer, energy assistance. Talked about IT investments, talked about progress in getting employees working at home, and sort of set the stage for a plan to transform the department from the old office-based model of the past 50 years where people have to show up in person to obtain benefits to one where a lot less of that is necessary. And just one comment on that, since we last were here, we've surveyed our employees, 95% of them want to continue with home-based work if they can. We know they're more productive. We've also gotten feedback from over 5,000 customers of the Human Services Department, people on SNAP, Medicaid, and other benefits, who actually 95% of them prefer the online approach, think it's much, much easier than it is to come to the office. And so we're building that into our plans for this year and next year. But it's a great, not that anybody wanted a pandemic, we've really had the opportunity to transform how we do business at HSD, and we appreciate you giving us the time to talk to you today. Number two, I should have had this be the first thing, but really want to compliment the leadership of this committee and all the members for making a choice to practice COVID-safe practices. You know, as government officials, you have an exemption. You could meet in person. You could get together. We can't be with you, but in person. But and I really applaud you for the initiative you've taken to make this safe for your members and all of us. I have not a day goes by that I'm not referring other committee chairs to you to see how this works. There's a broad belief in state government that these online meetings don't work at all. In our experience at HSD, is they work much, much better in this mode where we can see all of you. We know who's talking. We know if the meeting is in session or not. And so I just want to thank you for your leadership on that. And, you know, as we fight the pandemic, I think the single most important thing is the leaders in New Mexico set the example for everybody. And we never ask anybody to do anything we're not willing to do ourselves. So I'm bragging on you all a lot. And it's particularly appropriate being the Health and Human Services Committee that you're doing this. But It's a really big deal to us, and we really appreciate it. So thanks for that. And I guess with that, Nicole, maybe we could bring up the slides and get going. Today, we're focused exclusively on Medicaid. We made a deal with you all that we would answer every question you had about everything but Medicaid last time, and this time we want to stay focused on Medicaid. So that's what we're going to be doing. I have with me today a woman who we're just incredibly fortunate to have brought to New Mexico. The governor played a big part of it in it. Nicole Como, she's had experience. She's an attorney. She's had experience working for CMS. She's worked in the exchange and helped run the exchange in Kentucky. And so she's got a lot of background on all things related to Medicaid and actually covering the uninsured, which is going to be a big topic we're going to get to today. So let's go to the next slide. And as is our custom, we want to just remind you that our mission at HSD is to transform lives, and that our goals are to help New Mexicans to communicate more effectively with the public, to make access to our services easier. I just touched on that. And to support our employees, to support our state government workers, particularly during this time where there's a lot of fear about COVID. And we still have people serving customers in every one of our offices. And they're out in the parking lots doing it, helping people in their cars. And people really appreciate that. So everything we do and everything we say today will tie back to one of these four goals, and everything we're doing is intended to improve our ability to serve the people of New Mexico and to continue to build trust and accountability to all New Mexicans and taxpayers who fund these programs. Next slide. I wanted to introduce you to the Burdens. Emily is a stay-at-home mom. They have two younger children, Elena and Tate. Tate has cystic fibrosis, and Jose was laid off from his job due to COVID-19 and has also lost his health insurance. Very common scenario in New Mexico in March and April and May. They're working, trying to figure out how do they get the kids back to school, who's going to work, how do they get coverage for their family for health care, because this is a very, very scary time not to have health insurance in New Mexico or anywhere in the world. And Elena, the 7-year-old, comes home with a low fever. And because of Tate, and concerned that he could get infected and he has pulmonary disease, it could be devastating. We take Elena to a drive-through testing. They're delighted to find out they don't have to pay for their test. And then Emily reaches out to her friends on Facebook, and they point her, they say, hey, did you know that at HSD you can apply online for benefits? They send her a link, or she Googles us, finds us, goes to our website, and enrolls in Medicaid. And when I say enrolls, I mean she applies online and gets her benefits within minutes after that. We'll come back, as we always do, to let you know how they're doing and let you know how the programs that we're putting into place are better meeting their needs as we go on. And then Nicole, I think we're going to go to you, and I'm going to turn it over to you. From this point on, Nicole is running the show. She's the broadcaster. I'm going to be the color commentator. I'll be back and forth, in and out. But just to highlight some of the things we're doing, and in particular, I'm going to interrupt Nicole when I need to brag on the strong work she and her team is doing, because she's not inclined to do that for herself. So Nicole, take it away.
Just a second, Nicole. Before you get started, just want to remind the committee members of how you get in the queue for questions. At the bottom of the participant icon, if you click on that participant icon, there is a little hand. If you click on that hand, you'll get in the line to be asking questions after the presentation is complete. Thank you. I'll turn it back to you, Nicole.
Okay, thank you, Mr. Chair and members of the committee. Thank you, David, for that introduction. I am really grateful to be here with you all today and see your faces. I think I heard another legislator say earlier on that kind of miss this social interaction, so I second that notion. And I am coming to you all actually from my office, which I am very rarely in. I think I've been in about 3 times since the beginning of the pandemic. But as I think many of you know, I have a 3-year-old and a now 13-month-old coworker who make things pretty interesting. So they are at home with Dad, so we wish him luck. As usual, we've got a lot to cover in a relatively short time, although I will say again, thank you, as Dr. Grace did, for giving us a session to cover all of this. There's been a lot of work done, so we're excited to talk you all through it. We were asked to cover the following in light of the COVID-19 pandemic and public health emergency. I'll try to just refer to it as the public health emergency or PHE for the rest of the presentation. So we're going to run you all through an overview of the federal response because it kind of framed our ability to respond. We'll go into what we've done, and then we will talk about how the program has changed as a result of the public health emergency. That's really critical for you all to hear, I think. So we'll provide a high-level enrollment update there. Then we were asked to talk about access to care, and that ties closely to utilization of services. So we will run through some things at a high level there, and then finally get to provider networks and reimbursement rates. Of course, we plan to speak with you all about the public health emergency because it's top of mind for all of us. But normally at this time, we'd be speaking with you all about the normal business of Medicaid, which has actually continued to happen despite the tremendous work that the team has done to respond to the public health emergency. So at the end of the presentation deck, there is a considerable amount of information that we sent to you all about other Medicaid efforts, because I know this committee in particular is really passionate about the work that you all do and the efforts outside of the public health emergency. So we thought we would provide it to you, even though we won't cover it today. And you know that we're always happy to talk with you all at any time should you have any questions about those other efforts. Examples of things that are in the back of that deck are the supports waiver efforts, some data that we're seeing in home visiting, and also in some pretty interesting data on reductions in teen births and things like that. So that's at the back should you be interested in looking at those things as well. Okay, let's see. Oh, it's not letting me advance here. Try this again. There we go. Okay, so things have changed extremely significantly and quickly. And when everything feels like a priority and you're having to make tough decisions, it's really critical to stop and decide what you're really going to make your focus. So that's what we did as an agency, and we wanted to share those priorities with you all. So our top priority is preserving the Medicaid program as it exists today for every qualified applicant and ensuring that they have access to care. We also need to ensure in doing that our providers are adequately paid for that care so that they can continue providing those services. As Dr. Scarce mentioned, we also want to continue our investments in IT because that investment is the pathway to really improving how we deliver services and make data-driven decisions, maintain compliance with state and federal law. Finally, we want to build upon how we've responded to the pandemic, which Dr. Scarce also mentioned. So we moved staff home fast and changed how we did business fast. And as he mentioned, we're seeing really, really positive feedback from staff about being able to do that. And while Representative Cadenia's comments are well taken, it has been a really big challenge, but I do think people are grateful to be home. So it's an effort that I think we'll all continue to work through and try and improve upon. And that's been one of our goals that we wanted to lay out clearly in these priorities. Okay, so on that note, we wanted to provide a really brief update about Medicaid specifically. We decided at the very beginning of the PHE to focus ourselves much like the agency did at large in that last slide. Our first commitment was to members that we serve as well. Second, we wanted to make sure that our staff were safe and we were able to do our jobs. And finally, we wanted to take advantage of everything that we could in the way of the federal flexibilities that were coming out to make sure that we were helping New Mexicans through this in every way that we could. I wanted to also give a sincere thanks to the team at the Human Services Department. The response to this effort was driven by the entire team and really has been one of the bright spots in this challenging time. The Medical Assistance Division, I just wanted to tell you all that this team that you have here, as you all know, I'm newer to the state, is truly composed of incredibly dedicated members, and I'm so humbled to be part of this team. They've acted tirelessly and selflessly to make sure that we got the work done that needed to be done. They've worked long hours, digested thousands of pages of federal guidance, conducted complicated analysis quickly, and submitted dozens of waivers that allowed our providers to deliver care in non-traditional settings. They've deployed creative and rapid IT solutions, conducted outreach in new ways, organized food distribution and shelter establishment, and the list goes on. But the team cares so deeply about New Mexicans that we serve, and it's been so obvious in the way that they've responded, and I just can't thank them enough. So wanted to take this opportunity to call them out. So now we'll provide you all with an overview of the federal relief and flexibilities that we were presented with. So before I go into that in more detail, I think David wanted to set some context about the Medicaid population during this public health emergency.
And Nicole, you might be able to help me by moving the pointer around, but what this is a bar graph. And I think of all the things we're going to show you today, and we showed it to you last time too, a little with older data, this might be the most important slide we have. And that is that, so we have the bar, the height of the bars are basically your chances of having COVID depending on where you live. And on the x-axis, the labeling each of the bars, we've taken all the census tracts in New Mexico and grouped them by the percent of people that are at or below the federal poverty limit. And so you can see way over to the left, those will be all the census tracts where 5% or less of New Mexicans are below the federal poverty limit. And all the way over to the right is 40% or more. And then there are gradations from, of course, in between. And the reason this is so important is there's this myth out there that insurance companies are just making a ton of money on COVID because of, elective surgeries were shut down and other things like that were happening. And what's really going on is that's data from the Kaiser Family Foundation about commercial insurance companies. And those commercial insurance companies serve those three bars of people represented on the left of the graph, people who have incomes that are high enough to afford, or jobs that allow them to get commercial insurance. Whereas Medicaid kicks in more and more and more to the right side of the graph. And without doing the math exactly for you, you can see that if you live in a census tract along with where more than 40% of people are at or below the federal poverty limit, you're 9 times more likely to contract COVID in New Mexico so far during this pandemic than if you live in a more affluent district way over to the left. And what that means is that Medicaid costs are going to go up, not go down. And we're going to get into Nicole will talk about the additional federal match we're getting, which is substantial. We're very grateful for it, and it's completely insufficient to meet our full need. And so with that, I always like to talk about this slide because it's, if for those of you who know my role in the pandemic, I probably presented in a variety of venues, like 4,000 or 5,000 or 6,000 slides. But I think this is the most important slide I've presented in all those slides as it relates to the people of New Mexico and our Medicaid program. And with that, I'm going to send it back to Nicole.
Thank you. Okay, so there are 2 big buckets that we can talk about when we talk about the federal relief that have shaped how we've been able to respond to the public health emergency. So first, there are the congressional relief packages that we'll go over in a moment. You can see some of the highlights from those there. And then second, there are administrative flexibilities that the Health and Human Services Department, which encompasses the Centers for Medicare and Medicaid Services, have outlined for us or did at the beginning of the public health emergency, and those have continued to evolve. So we'll cover in more detail as well those flexibilities that you can see listed there and which of them we've employed to respond. So I believe you all are likely aware of these larger federal relief packages that Congress has passed since the beginning of the public health emergency, but we wanted to highlight for you, again, the most significant impact on Medicaid. And those two pieces of legislation are the Families First Coronavirus Response Act, so we'll call it Families First for the rest of the presentation, and the Coronavirus Aid, Relief, and Economic Security Act, the CARES Act. So Families First is actually, I think a lot of people hear a lot about the CARES Act because there's a lot of funding to states through that piece of legislation. But the Families First Act is actually the most critical piece of legislation for Medicaid because in passing that legislation, Congress took significant steps to safeguard Medicaid benefits for the exact reasons that Secretary Grace just talked about. They knew that Medicaid benefits would be necessary, and they also knew that there was a high likelihood of exponential growth in membership programs by the time they were working on this legislation. They knew that we would start to face that growth as a result of job and coverage loss in efforts to slow the spread of the virus. So they also knew that states would not have budgeted for that growth and that we would also likely be called upon to make sure that we shored up the safety net that serves that population. So similar to the last recession, they gave states an additional 6.2% match. And we'll go into that a little bit more, but you all have heard us discuss many times that we normally receive $3.54 for every dollar of state general fund that we invest. After this Families First Act, we receive now about $4.15 in federal funds for every dollar of state general fund that we invest in the Medicaid program. However, that money came tied to a maintenance of effort requirement that we'll cover. And as Secretary Grace has said, not only do we see, but economists across the country have also said that while it was a great support to states, it is not enough. The other thing Congress did in the Families First Act was allow states to extend Medicaid coverage for testing the uninsured at 100% federal match. We were the first state in the country to successfully implement that option and are seeing claims coming through that option indicating that testing facilities are using that to make sure that they don't incur unnecessary uncompensated care costs, and also to make sure that New Mexicans can continue to get tested for free without that concern. So you heard the Burtons take advantage of that option at the beginning of the presentation. The other thing that Families First did was make sure that there was no cost sharing permitted for COVID testing. And so that was an across the board requirement within that piece of legislation. So the CARES Act very quickly impacted Medicaid in a significant way because it established the Provider Relief Fund. That Provider Relief Fund put forth $150 billion in federal aid to hospitals and healthcare workers and $150 billion to support state and local territorial governments. Those awards obviously factored into how we made decisions about how we would try to support providers with the funding that we received. So that's why that legislation has been important for us to follow as well. Okay, so as I mentioned, there's a maintenance of effort requirement, we'll call it the MOE, tied to that 6.2% match. So what the maintenance of effort requirement does essentially is prohibit states from reducing benefits, adding any cost sharing or premiums, and most important, it prohibits states from disenrolling anyone from the Medicaid program for the duration of the public health emergency, and that's retroactive back to March 18th of this year. So to give you all some sense of what that means for us, in normal circumstances, we disenroll about 7,000 people per month. That's a little less than 1% of the existing membership. So you can understand how quickly that can make the overall membership of the program grow. And that's in addition to those folks who we talked about who are unfortunately losing their coverage and their jobs. So Another thing to note and remind folks is that because we are primarily a managed care Medicaid state, that means we pay a per member per month capitation rate for each of those members. So again, you can imagine how the growth in the program is happening quickly, and the costs associated with each of those members is coming at us very quickly as well. Okay, so the 6.2% increase and that MOE are tied to the Public Health Emergency Declaration from the Health and Human Services Secretary. There's actually 4 different declarations. There's a slide in the back of the deck if you are a nerd like me and find this policy policy efforts very interesting, but they're in the back, and this one in particular is tied to the Secretary of Health and Human Services, and the declarations are for 90-day periods or until the Secretary terminates the declaration. So there's a possibility that he could end it prior to that 90-day period coming to a conclusion. So on July 25th, he again extended the public health emergency. So at this time, we are operating under a declaration that will carry us through October 22nd. We receive the 6.2% match on a quarterly basis. So because at this time, we expect that public health emergency to extend at least one day into that last quarter of the calendar year, we are anticipating receiving another quarter of that 6.2% match. We won't know that for sure, obviously, until October, but it is, I think, a fair assumption at this point, and so how we've built the budget that we'll be presenting in a few weeks to LFC. So this will give us the increased funding through the end of the calendar year. And we wanted to tell you all what that has looked like in dollars for us as a program. So you can see that it has resulted in an additional $136.8 million to support the program in quarters 3 and 4 of state fiscal year 20. In quarter 3, which was January to March of this year, we hadn't really begun to feel the effects of the public health emergency. So we were able to revert some of that money back to the general fund, as you all know from the special session, but wanted to make sure that folks understood why that had happened. We didn't really start to see this exponential growth that you'll see in a few slides in that January to March timeframe. We really started to see the uptick significantly in April. And that is when we started to quickly absorb that 6.2% increased match. So we also received the first quarter of state fiscal year 21 increased match, which is about $73 million. And as I said, we anticipate another quarter, which will be quarter 2 of state fiscal year 21 and the 4th quarter of the calendar year. And we anticipate about $74 million. The numbers change because it's tied to the number of individuals in the program. So our first allotment was smaller. It was about $60 million, and they've gone up as the program has increased in size. Okay. So that covers the Families First legislation at a high level, and we just wanted to share with you all the impact of the CARES Act as far as it has been made available to us to date. This has been a challenge for Medicaid directors and governors across the country. There was a reluctance to share this information in detail at the beginning, but from the information that we do have at this point, you can see that the data would indicate that about 1,900 New Mexican providers have received about $540 million in federal relief funding. So as I said, we're tracking that as we make decisions about how we can try to help providers who we're hearing from on a regular basis. Okay, David, I think you wanted to jump back in here at this point in the conversation before we move on.
Yeah, I made reference to this earlier. Sorry, just checking my volume. I made reference to this earlier that the funding would be insufficient, and not just my opinion, people all over the country. I think that because of the distribution of COVID across different income groups, or at least census tracts, it puts a disproportionate effect of COVID on the Medicaid program. A lot of folks, and if you want to, you'll have access to this deck. You can click on any of these links. But in general, people are saying it should be 12% or even higher. Some people say it should be, like about what it is now for every 1% increase in unemployment. I think that might be, a little bit high. But we believe that there's no amount of balancing our budget that can absorb the increase in costs between now and the end of this fiscal year. So we are not proceeding with any kind of drastic reductions in anything, provider rates or other things. Well, you just saw we're constrained. We can't really disenroll anyone or do anything like that, which we don't intend to do anyway. And until we get more of a sense of what's going to happen, let's say after the election, but particularly in the first and second quarters of calendar year 2021. So I wouldn't say we're in a holding pattern. We certainly have lots of plans and analysis and know what the levers are if we need to pull them. I think our congressional delegation is well aware of the need to sustain funding to the Medicaid program through at least June of 2021. And also, we want you all to be aware of that need, and we'll let you know what you can do to support us in our efforts to make sure that continues. Nicole. Nicole, you're on mute.
Thanks. So we told you about the federal parameters that we're working within, and now want to tell you about what we've done since the public health emergency began. So first, struggling with my different platform familiarity here. Okay, so we wanted to talk to you about our engagement with stakeholders. We have conducted over 460 leadership level stakeholder engagements since March at about an hour apiece. That's almost 2 weeks each month in stakeholder engagement efforts. And I want to caveat that this data was gathered from my calendar alone. So there are many other leadership engagements that Secretary Grace and our Deputy Secretaries, Carrie Armijo and Angela Madrano, led on behalf of Medicaid. We had to divide and conquer, as you can see the long list of stakeholders there. But this is also an incomplete list of the stakeholders, but these meetings started at the very beginning of the public health emergency and were intended to make sure that folks knew what we were doing as soon as we could get that information out to them, and also an avenue for us to hear from all these stakeholder groups so that we could try to help wherever we could in responding and doing so as quickly as we could. Despite those numbers, I will say it feels every day like there is more and more we could do. So we keep pressing on there. So on March 23rd, New Mexico was the first set of states to receive approval on our comprehensive waiver request. This has been an ongoing effort, but when we received the list of flexibilities from CMS, I began talking to Secretary Grace about what we should apply for, and he said, let's get all the tools in our belt. So we did. We applied broadly, and the team worked so hard. And since that time, we've received 36 waiver approvals for flexibilities, 36 waiver flexibilities. Many of them are lumped into the 1135 waiver. But that's nuance that is also included in the appendix if you're interested. And we've also received approval on 6 disaster state plan amendments. And we have more that have been submitted in the past few weeks that we're waiting for approval on as well. To give you all a sense, the 1135 waivers really allowed us to do things that were things like allowing different flexibility for providing services in alternative care settings, whereas the state plan amendments were changes to rates that we wanted to provide on a temporary basis during the public health emergency.
Hey, Nicole?
Yeah.
Could I just say one quick thing? That is, I want to make sure people know when they're looking at this. This is really a miracle, and that this is an enormous amount of work. And keep in mind that if you're in a small state applying for a Medicaid waiver, where you have a relatively small staff, or you're in New York where you have a Medicaid staff way bigger than the whole HSD department, it's the same amount of work. So for our small cadre of Medicaid experts to spend this much time And you also need to know we were first across the finish line nationally on a number of these. It's just amazing, amazing work. And it just with the size of our Medicaid group, Nicole, I just wanted to get it out there how impressed I am with what you led during this period of time.
Thank you. Yeah, I can't say enough about how much this team has worked. So, you know, all of those waivers result in changes to the program, and that requires us to put out guidance. So there have been 14 different letters of direction to the MCOs that encompass that guidance, and 7 different comprehensive supplements to the providers about the things that they need to change. And then finally, we've issued 391 deliverables to the MCOs to monitor their implementation or gather information. So really do want to give them credit as our partners too during all of this. They have really stepped up to the plate, and they have taken on things that are outside the scope of the normal responsibility of a managed care organization. And they have very quickly responded to all of our deliverables without complaint, and I think have really shown how much they care about serving New Mexicans during this time as well. So there are too many waivers to go through in great detail, but if you look to slides 44 and 46 in the appendix, there is a list of a high-level list still of the flexibilities, and they are all also available on the website. But I think some of the most critical things I'll just call out. I think most important really was quick and early implementation of telehealth flexibilities to allow for the provision of services through new modalities without the threat of HIPAA violations for providers. Allowing providers to deliver services in alternative care sites, which I already mentioned. So the temporary shelters that have been set up and also drive-through testing sites. Allowing coverage of COVID-19 testing for the uninsured, allowing payment for services provided by family caregivers in the home. We know a lot of people, were no longer working in their offices, and so they wanted to take care of folks in their home that they may have normally had other caregivers for, so allowing for that option, and then extending current prior authorizations through the rest of the public health emergency to try and alleviate burden in any way that we could on providers who, had such a difficult job to do at this time.
Just one quick question on that point. Were you able in any of the waivers to get permission for undocumented to get free testing?
So testing is free across the board, and we did utilize, I'm sorry, got an alarm going off. We did utilize the Emergency Medical Services program to allow for testing. We expanded that coverage to testing for immigrant population, and we did stop that extension at testing and not treatment for a number of reasons in working with CMS, but that waiver authority is also, listed at the back of the presentation.
Great. Thank you. Thank you, Nicole, for doing that.
Thank you, Mr. Chair. Okay. Lost my place here again, so let me click over. Okay. I think I covered what I intended to on the flexibilities, but I know that was certainly a focus of the committee. So if there's additional questions, I'm happy to take those now or later. So in addition to the Medicaid public health emergency response, many of our staff also switched over and dedicated their time to the Emergency Operations Center efforts. I know you heard the Deputy Secretaries Angela Medrano and Carrie Armijo speak to this. HSC worked on food and shelter efforts, and while many of our staff volunteered hours, I'd be remiss if I didn't mention Kathy Slater-Huff, who has worked endless 100-plus hour weeks to organize food delivery with our partners, and so proud of the amount of food that we've been able to get out to New Mexicans at this time. Okay, and finally, outreach to the members. This is, sometimes challenging. There's so many different ways that we can try to reach out to the members. So we've changed banners on websites, submitted waivers to get more presumptive eligibility determiners to help get information out and help get people enrolled. worked with Coverage Network, which is what we're referring to our group now here, I believe, the Office of the Superintendent, Be Well, which is the exchange, and the New Mexico Medical Insurance Pool to pull together outreach materials to make sure that New Mexicans who were facing loss of coverage knew that no matter what your circumstances in New Mexico, you're covered. And this coordination, I would say, is another true bright spot in this effort. It has been so great to be able to have these entities come together and know that we are all working comprehensively to make sure that there's this spectrum of coverage for New Mexicans. All of us took these materials and disseminated them through each of our stakeholder channels to try to make sure that we got the word out so that folks knew where they could go if they needed help. Okay, so let's hop into the program since this all began. Told you I wanted to give you an enrollment update, and I am running longer than I wanted to, so I'm going to probably talk even faster. Stop me if you need me to repeat something. So to give you the context of the Medicaid program, 40% of all New Mexicans are enrolled in Medicaid, and as of June of this year, we go back to June because there's always a retroactive adjustment after folks potentially enroll and are eligible for a retroactive 3 months of coverage. That amount is usually not that large, so safe to say that our enrollment is around this 870,000 beneficiary mark at this time as well. Then 42% of our beneficiaries are children. And since March, this is the key point, we have seen 6.7% overall growth in enrollment in the program. Given the impact of COVID-19 on the tribes, we wanted to also highlight a 3.1% growth in the Native American population's enrollment since March. It's an increase of about 4,000 people, and there's more information on that on slide 57. Okay, so this slide is just intended to give you a visual representation of what's been happening. On the x-axis, you have dates from January of this year through June of 22, and on the y-axis, you have the Medicaid membership. So in December of 2019, when we projected our normal program growth, so prior to the pandemic, it looked like that green dashed line at the bottom of the graph that you can see there. That's normal growth in the Medicaid program. What is happening now, in June, we did another projection, and you can see this curved line that both the solid green line and the dotted green lines are arcing upwards here with some exponential growth. The difference in the two lines here is to indicate what will happen if the maintenance of effort requirement continues past the end of this calendar year. We would expect that growth in the program to continue as well. However, if the public health emergency declaration comes to an end at the end of this calendar year, if the declaration is not renewed, what would then happen would be depicted by the dotted lines here, where there's a downslope where we would slowly disenroll those folks who are no longer eligible for Medicaid. This bubble up here, we didn't put a description of this acronym. That green line assumes the continued maintenance of effort requirement and also assumes a 10% unemployment rate.
Hey, Nicole.
Yeah.
I want to say one thing a different way than what you said it.
Sure.
But you have to go back.
Another one?
The green dashed line, when Nicole says it's our projection, it's also our budget. And the dotted line is what's happening. So you're aware. Thank you.
Great. Thank you for calling that out. So again, to give you some perspective here on this, the normal growth in the Medicaid program is usually about 0.1% a month. Since the public health emergency, we're averaging growth of 1.5% per month. And the PMPM that comes with that population. You all are familiar with this graph, just another depiction of the same growth in the program that's happening. And you can see coming close to what was the highest enrollment that the Medicaid program has seen in recent years. Okay, David, do you want to check in with the Burtons here?
I'd be delighted to. You can see also by county, and we know based on feedback, you like to see these maps of what kind of how these programs are affecting your constituents. So we've given that to you on the left. Elena, the 7-year-old, is missing her friends. She's been cooped up at home all summer and really wants to get back to school. And fortunately, she lives in a district that reopens on Labor Day. But Emily has actually become extremely anxious. She's the mom about both kids being out, catching the virus, bringing it home. But, you know, she's watching him at home. When she finds out that she can schedule a behavioral health appointment over the phone, I mean, she's absolutely delighted. And let's go to the next slide. And I think that's the telemedicine slide, Nicole.
Yeah, we can keep moving so that, there you go.
All right. So you can see, and I want to brag on Nicole's team one more time, probably more after this too, but they were the first in the country to get the exemption from CMS to allow us to pay providers an equal amount for seeing somebody on the seeing them on a video visit or over the phone. The slides are shifting around here a little bit, Nicole, but if you could go to the slide with the graph, you can see that we had and as a result of that, it motivated providers to do a sharp uptick in telemedicine. And two things about that. Number one, I think that we're going to see that stay up for a longer period of time. I know I'm still doing a lot of video visits in my own practice, and I think UNM will go from from where we are now, all video visits, to a hybrid model, if you will, of some videos, some in person. But one of the really, really interesting things we're hearing in the behavioral health community, and it's an anecdote, I don't have good data yet, but all over the state, when I talk to providers, they say, you know what's really strange is the televisits actually work better than in-person visits. And I say, well, what do you mean by work better? And their answer is people are more forthcoming. They open up for some reason more on a video visit than they do when they're sitting in your office. We're getting to the real issues with people weeks earlier than we used to. So this may well be a keeper in terms of how we manage behavioral health in the state. And I just can't tell you how delighted I am to hear that it works better, because many of you come from rural districts where you know that the challenge of getting appropriate behavioral health services to folks in small communities that have no providers at all has been something we've struggled with in New Mexico probably for more than 20 years. So real pleased about that. If you go to the next page, Nicole, you can see again two maps on the left, telehealth claims, and these are how many folks in your counties are getting telehealth. And this is just increased telehealth visits, and you can see the percent increase that occurred in your county, with some of them being like a factor of 10. So we're really excited about this, really pleased. You know, we've done so much to try to rebuild behavioral health in the state, and this is just one of those unexpected gifts from the pandemic that's a real breakthrough that I think is going to enable us to level load, if you will, all behavioral health services in the state. So even a provider in Farmington to provide mental health services for someone in Lee County without, and that be the norm. So more to come on this. I think this is going to be a big part of our future. We're not getting rid of in-person behavioral health visits by any means. Those can be very valuable, but I thought you'd find it fascinating what our providers are telling us about how well it's working. Thanks.
Thank you. Yeah, so we know that Dr. Bowen talked to you all a little bit about this in his presentation, but when we dug into the Medicaid claims data and saw these numbers, we felt like we needed to share, as Dr. Scrape said. So I know there's a blank in Union County up there in the corner. We don't have good data there for some reason, so we're digging in and we'll update it and send it to you all. And then, as Dr. Scrape said, we're now at the point, believe it or not, as we're still implementing, we're also working on plans to unwind all of this work. And this flexibility is absolutely something we're working on how we could continue. So this section, we're supposed to be talking about access and how we maintained that during the public health emergency, just to bring us back. So looking at long-term care and specifically the community benefit folks. There was some concern about ability for that to continue to happen and make sure that we were still getting those benefits out to folks in the home. So wanted to show you all that we've been monitoring those allocations. And 5,028 of the 5,789 allocation slots are currently filled. As you all know, similar to the DD waiver, likely that there are some slots that are held in case of emergencies, but I know the team is working really, really hard to keep those slots filled and keep those allocations going out. While I said we do have 100% of our staff working from home, this is one where staff have had to come into the office and have done so every day since the PHE to make sure that we can keep those allocations filled. Another note here, we are still on track to implement electronic visit verification for self-directed community benefit by 1/1/21, which will allow us to track the delivery of these services even better. Basically allows those individuals providing those services to let us know that they have completed that visit electronically from the site of service. So those personal care service providers who already have electronic visit verification, we've been monitoring that data as well. There was, again, concern about this at the beginning of the PHE, and I believe that persists. We heard reports of members refusing services, and so we've been looking at how this data has played out. And as you can see, in the first quarter of the calendar year, there was a dip in the provision of these services, but by the second quarter, starting to catch up to normal, and in that third quarter, expect it to be even higher. One last note on that slide, actually, was just to note that one of the waivers that you will see listed in the appendix is a 1915 Z Appendix K Waiver, and that allowed for retainer payments in hopes that we could avoid losing staff from this critical part of the healthcare delivery system should they start to have lots of refusals. So CMS has put lots of back and forth on that, and we're finally getting that approved. Okay. Last, we knew that making sure that we could keep access to providers was making sure that they also got paid timely. So we cut the amount of time that the MCOs normally have to adjudicate claims. We're requiring them to pay 90% of their claims in 15 days instead of 30, and 99% of claims in 30 days instead of 90. We also require that they report to us weekly on the implementation of any of the temporary rate increases, and that they implement those in a timely fashion. So you can see here, these graphs show how quickly the MCOs implemented the hospital rate increases for both non-ICU claims and ICU claims that we put in place to help support the hospitals during the PHE. Okay, so utilization is another way that we can look at access, and also how we're monitoring the use of Medicaid dollars at this time. These are some notes about why we have concerns about the data so early on in the public health emergency. I know it feels like it's been long to many of us, but in terms of data, it is not enough time for us to feel confident in the data that we're looking at. There's delays in reporting due to disruptions, closures in offices, staffing, et cetera. So we just want to caveat all the data that we're putting out with those concerns, and we do expect it to change. That said, we're following this closely, constantly analyzing the data, especially with our actuaries. And early data did show that while there was decreased utilization for some providers, there was also increased utilization for a significant number of providers as well. April and May encounter volume dropped far below the prior year from the public health emergency. But the resurgence by the end of May really was significant. And by June, there was an increase actually 2.4% above the prior year. So we are getting back to normal on this front when we're looking at the claims data that we have access to. That 6.6% that you see overall is still negative just because the dip in April was so significant, but as you can see in June, fairly recovered. David, you want to jump in here and talk about this a little bit more?
Yeah, I was also going to, I was also going to add on the last slide that despite claims being down by 6%, costs are overall up by 9%. So people getting maybe more expensive services, even though they're getting less services. Also, the provider rate increases would naturally be included in that increase in cost per service. And so, again, that green dotted line that's the budget, or the green dash line that's the budget, and the rising dotted line, that 9% there is part of what's filling, what is taking us above. Okay, now next slide, Nicole, thanks. This is again the same data in a little bit different format, so you can see the trend. We just picked a couple of folks. You can see hospital claim. We picked a couple of types of providers that would be most affected by the pandemic. You remember dental offices almost shut down completely, and you can see the green dotted line on top, the dark green dotted line on top, where claims went almost to zero during the early part of the pandemic. We started reopening in May, if you remember that, and had COVID safe practice guidelines. The medical advisory team did all that work to say how dentists could reopen safely. Same with hospitals, a big divot in April when all elective surgery was put on hold and the like, but they're gradually catching up as well. So really significant decreases. But then if you look at the dollars that we're paying out, or the dollars of claims that were billed, you can see that actually it didn't drop anywhere near as much. And so on those two graphs, you've got dental and claims paid in dollars and others. I think some offices and some hospitals got caught up on outstanding claims, and that's why some of those payments came through then. But this goes back to the very first slide I showed by census tract income rates of COVID, that at least in Medicaid, we're not seeing anything related to the kind of windfall savings the commercial plans have experienced.
Okay, thanks, David. So one of the last things we wanted to just let you all know about, you've heard about this in the press conferences, in looking at utilization data, where we did see a concerning decrease was in childhood vaccinations. So compliance is down by 17%. So we've been working, as you can see reflected in the graph here. So we've been working with DOH and many other stakeholder groups and using one of our contractors to help with a campaign called Don't Cancel. And we've talked with the Pediatric Society about this plan, so they can work with providers to make sure that they're ready to work with parents so that they can call, hear about safe practices, and get reassurance that they'll be safe when they get those babies in for those well baby checks, vaccines, and all of the other critical care that's really provided during those appointments. Next steps in this effort are a flu shot, a text and email campaign, and a targeted campaign to remind pregnant women to get flu and Tdap shots, where we've also seen a decrease in compliance.
And Nicole, for those of you who watch the press conferences, we are really focused in on vaccination right now, but also we're starting a series on getting needed care, because there are a lot of the screening procedures, colonoscopy, mammography, cholesterol screenings for heart disease and the like, have really dropped off as well. Diabetes care and keeping diabetes under control. So we've got a campaign going with our delivery system partners and the medical advisory team. And in press conferences every single week, you'll see a new topic. We're bringing up a website also about getting needed care on the DOH site that will inform people about this as well. It's a really big deal for a variety of reasons. This group is most concerned, as we all are, about the quality of care and making sure people get what they need. But the costs later for not getting that care go way up. And then that takes away from our ability to serve more people. So we're on this. It's important. And you'll be hearing more and more about it in the coming months.
Thanks. So as you can tell, we've been paying attention to this utilization. We heard from providers across the state that they needed help. So we started doing analysis and then started working to figure out how we could push out some dollars. What's critical for you all to know here, and one of the questions that I heard come up in a previous hearing that was mentioned would be brought up again here, is that there was concern about the MCOs keeping those dollars during that time and not actually having to pay for services. So when we put these increased when we put the increased provider rates in place for response to the public health emergency in particular, we did not increase the MCO's capitation rates in kind in recognition of what were likely some unused capitation rate dollars. So we asked them to essentially absorb those costs with their existing rates, and they have done so, and we've been tracking that closely with them. So in slide 48 of the appendix, you can see a breakdown of all of the providers that we're trying to reach. This is the high level in providing some support. We set aside what is $240 million total computable in our fiscal year 20 budget to try to put some of these payments out. While CMS has been great about approving waivers quickly, they have been less quick in approving some of these rate increases. So these increases, some of them are out already, others are still in process, but they'll be retroactive into fiscal year 20 where they were already budgeted for, and providers will still get to see those funds. So if there's specific questions about that, happy to dig in there. Oh, sorry. And I think the only other thing that we wanted to note on this slide is that we'll continue to work with providers, but many of you have probably seen the notices. So those rate increases are temporary, like I said, in fiscal year 20. There are only 2 that are continuing into fiscal year 21, and that is increases to the hospitals and nursing facilities for 1 additional quarter. And then those increases would stop as well in light of obviously our budget situation. So thank you all again. I know I went longer than I had planned, and happy to answer any questions. But before we go to that point, I want to let David close us out here with the Burtons and any other comments he may have.
Yeah, I just want to summarize that, I think the summary of what's happened in the last 178 days, which is the number of days since our first case in New Mexico, is just an incredibly rapid and agile response on the part of our Medicaid team to actually attain every possible waiver from CMS to expand coverage to a population that's now newly unemployed and desperately needs healthcare coverage. That the federal government is giving us a nice increase in what they're paying us. That really helps us a lot. Probably not enough to cover all the medical expenses in Medicaid, and you're going to hear a lot more about that as the months go on. We're watching that closely. And that last, they're just an enormous number of New Mexicans, over 50,000, who are actually have healthcare coverage who wouldn't have had it if it hadn't been for the tremendous response of our team. The Burdens, the dad, Jose, secured a new job with a small business, but they don't have benefits yet. And they were worried that their income would make them ineligible for Medicaid, even though they're behind on bills and, working both ends of burning both ends of the candle to make their financial obligations. And then they hear their coverage will last till the end of the public health emergency, which gives them time to get back on their feet, given those constraints that CMS very, very, very wisely put on these programs. And I just want to say that we're, even though there are limitations, we believe in them. We think they were very smart for CMS to impose. It's very helpful to us to be required to keep people on the rolls during this period of time, because we think the vast majority of people need it anyway. And in any case, the Burdens know that eventually the public health emergency is going to end. We refer them to Be Well, New Mexico to get coverage there. And that is going to move us into the next topic on our agenda, which is different coverage options. I can't resist pitching to all of you, and can I have 1 more minute, Mr. Chair, just to walk through this quickly? We have seen 325 cases a day in New Mexico, in some significant part due to a lot of large gatherings that occurred over Memorial Day and 4th of July weekends. And we're really reaching out to everyone, the public, to you as leaders in your communities, to say, hey, really have a great Labor Day with a small group of people. Last week, it could only be 5. Now it's up to 10. But stay outside, lots of hand sanitizer, some good sanitation, no grouped food on a table where everybody goes and picks their food up. That's, at least during this time of our lives, it's a little dangerous. And then still enjoy the holiday, but stay 6 feet apart, keep those masks on, and you're welcome to take this slide and send it out to all your constituents on your mailing list. If you did that, we would love you. So with that, I think we stand open for questions. Thank you.
Very good. Thank you both so much. A fascinating presentation, and I think we were all impressed with the responsiveness of the department and of the Medicaid program to this incredible catastrophic pandemic that the state is dealing with. So with that, we'll go to the committee for questions, and I've got 3 people lined up for questions already. We're going to start with our co-chairman, Representative Armstrong. Let me just say before we get started that we've only got really about 35 minutes left, so if you could keep your questions to the point and brief, that would be really helpful.
Thank you, Mr. Chair, and thank you, Secretary Scrace and Director Camo. It's really, really impressive how much you've done, and I really appreciate the data. That's really helpful. And I'll try and keep this brief, Mr. Chair. I'm really interested in the telehealth and behavioral health phenomenon. We heard that same thing from the providers when we had our behavioral health committee. And but my question is the allowance of, just clarification, is the allowance to do so much telehealth? You said we were the first in the country to get a waiver. Is that going to go away? Our ability to do as much telehealth as we're now doing? Is CMS going to pull back on that?
Let me just start from the clinical side, and Nicole can tell you about CMS. Real briefly, I hope it doesn't go away. I mean, if our providers are saying it works better, why would we stop? Now, there's some technical issues about the payment structure of Medicaid payments that roll into Medicaid, and a Medicare payment is based on the clinician's time, the office overhead, and malpractice insurance. And so there may be some sorting through on the office overhead, whether we're going to be allowed to pay for office overhead for a telehealth visit or whether that would change. But I think we should adopt and keep everything that we've learned during this pandemic that works better than the old way of doing that. We talked about that, how we're going to run HSD offices, and the telehealth is the best example I can think of. I know at UNM, I was just talking to Mike Richards last night, who's their interim chancellor at the Health Sciences Center. That's a big focus of theirs as well, is how do we preserve that telehealth and keep people from having to do all the travel when that works just as well as an in-person visit. And Nicole, on CMS, are we going to have the flexibility to keep this if we want to keep it?
Yeah, the majority of this is actually at our discretion, and so we have plans to keep a lot of this in place. Some of the nuances are up to CMS. So, for example, providers are subject to potential HIPAA violations for using certain platforms, and those are things that actually CMS has been in conversation with the National Association of Medicaid Directors about looking at changing as well. So that we can all continue this. I think states across the country realize what a great way for us to deliver services this has been, and are thrilled that we were all able to just do this so quickly. So we can share more information on that with you, Madam Chair, as well.
Thank you. I appreciate that, and not just for behavioral health. I mean, right. I mean, we do have to improve our broadband and our access and so forth, but what a wonderful potential opportunity for particularly people who don't have transportation or rural areas. And I can just vouch personally, my daughter was going to New York for a clinical trial every 4 weeks. We had to travel to New York to Sloan Kettering. We do those visits virtually now. And it's so we have not missed a beat and have not had to travel to New York. So it's I think it works really well when you have connectivity. different systems work differently. So we have, the system they use versus something more local. Not all of them work as well. So I'm sure that CMS will keep working on that. So I'm glad to know that is not one of those temporary waivers that will go away. My next question is on all the projections for visits and claims and so forth is dependent on claims getting in. So what's the claims lag? I'm not sure how long people have to bill under Medicaid and what the usual lag time is, because I would assume there's some additional lag occurring if people are not in the offices as much. And so do you expect to see some of the data that you have now change a bit as claims get caught up?
Looking at Secretary Grace here to see if he wants to chime in, but I will if you aren't going to.
I'll just say real quickly, I think we are catching up. I think, dental offices who are largely closed up, but a lot of people did do their best to catch up during the downtime. But MCOs, as Nicole said, have a shorter time frame to pay the claims. I think that I forget what the required time to submit a claim is. It's set by the MCOs, and it's going to end up being a multiple choice answer. I'm pretty sure it's 60, 90, or 120 days in Medicaid, with exceptions being made, but I don't know the answer off the top of my head. I used to know that.
Yeah, thanks, David. So regarding catch up, I actually just got some interesting data last night. I do think folks are catching up. Madam Chair, I'm sorry, virtual forum, I'm very bad about keeping with protocol here. So Madam Chair, members of the committee, I do believe that folks are catching up. We're seeing that our encounter claims numbers are looking very similar to the utilization at the same time last year. There was a significant period of lag, though, where right after April, where we saw not the numbers that we would expect to see in May and June, but we're getting there now at the end of June and through July. And on the number of days, I believe it is 90 days for timely filing, but we did not waive that, so folks are hopefully still submitting within that time frame.
Great, thanks. That's helpful. I was particularly thinking about that issue because I got a call from a constituent yesterday who got a claim or got an EOB and a bill for services that were 14 months ago. And so I know that in commercial, it's a longer time they have to bill. And but that changes all your numbers about your claims data, your encounters, everything, if those claims come in really late. So I was just wondering what it was looking like in Medicaid. And along those lines, if there was a provider rate increase, say today, that's still in effect, but those claims don't come in until after that rate increase has gone away, it is retroactive, correct? Okay.
Yeah, claims are paid based on the date of service, not the date of submission. So whatever fee schedule is in place, and I want to just publicly apologize to our managed care companies and say that they're really, really good at keeping track of that because there've been so many changes. They program their system, and the first step is when what's the date of the claim, and then it pays according to the rate in place at that time.
Okay, thank you. And one final question. And I know this isn't necessarily your area for monitoring childhood vaccination rates, but you are part of that campaign and helping to do that. With schools not in session in person as much, and that's the primary area that monitors childhood vaccinations. Any comments or thoughts or different initiatives that are happening to try and track that? And I know it's not your area, it's more DOH, so you don't have to spend much time answering that question. I'm just throwing it out there.
Yeah, I think it is, Madam Chair and members of the committee, it really is our area too, for two reasons. One is we work closely with DOH. 54% of kids in New Mexico are on Medicaid. I think one strategy is reopening schools, which starts on Tuesday in almost not all counties, but the majority of them. And then, kids are required to be up to date on their shots. Second is that the MCOs actually have a fairly significant financial incentive in Medicaid to hit a target for childhood immunization. It's one of our quality measures as well. And then third, Nicole told you, we're working on the campaign, which includes me at the press conference. I mean, you have to go back about 8 weeks till you get to a press conference where I haven't talked about the importance of staying up to date on immunizations for kids and for adults. So this is very much a Medicaid thing, if you will, and we're heavily involved with DOH in it.
Great, thank you very much. That's a particular area of interest of mine. So thank you for all those efforts, because I worry that it's gonna our rates are gonna fall off. So thank you. That's all I have, Mr. Chair. Thank you once again for the great information and for including in the slide deck all the other information that you're not necessarily presenting today. So we've got the resources and ability to look more closely. And again, I just appreciate the data-driven decision-making that's happening around COVID and in Medicaid HSD. So thank you.
Thank you, Representative.
Chair, and it does turn out that, well, we at least have a belief that using data to make decisions results in better decisions every single time. So.
Who would have thought? Such a strange notion. That's good. We have a question from Representative Phelps Anderson, who's with us by telephone. So would you care to put your question to the panelists, Representative Anderson?
Senator, can you hear me now?
We can now. Thank you, Representative.
Thank you, Senator. Senator, my question is to Dr. Scrace, and it starts with a very long story told in short form. In Southeast New Mexico, we have undoubtedly the largest pediatric practice in this quadrant. Earlier this year, they had a difficulty with vaccines that they give to children. And so I listened today, I came in a bit late, but we were talking about immunization of children and what a great job individuals are trying to do. But nonetheless, I thought, well, this is a classic example. The right hand doesn't know what the left hand is doing. And this story starts, I'm going to fast forward through it. At the end of March, there's a death in the family of a nurse that's required to report on a very timely basis, vaccine temperatures and other things. She did it instead of doing it on a Friday, she did it on a Monday. This sort of snowballs into, well, you're not going to get any more vaccine. Well, so I'm very frustrated about this. It deals with a constituent calling me on this, and I'm looking at very old notes. But somewhere in this became a fine of $95,000, even though it wasn't CDC required, looking at my notes. And I think now that I'm getting farther in my notes, I see DOH, doctor. So, doctor, will you please have whoever it is in government who wants to immunize children make sure that the practices that are doing this job, and they are a full VFC state vaccine provider, gets the vaccines, because I think they do it for free for these children who I think have to have it if and when they return to school. So what is the logic of a bureaucratic impasse over a regulatory foul that they agreed? There was a death in the family late in March. This is bureaucracy out of control, doctor, and I know from my prior experiences with you, you were keenly interested in that. And if you could help me run that down, I tried to call DOH and it's a very complicated switchboard up there now in Santa Fe, and it does not always result with your ability to get with whom you're looking for. So that's just a plea. If there's a question in there or response, I would appreciate it. But I am just so easily frustrated when I see bureaucracy run amok because everybody's doing their job, but the children aren't getting the damn vaccinations. So that's where I'm at, and I appreciate you looking at it. This mishap started back in March, and I don't have this note dated, but nonetheless, it's apparently still going on. The Carlsbad Clinic on the Hep C for babies ended up having to pay a fine in order to get vaccine. And I think this is really something that ought to be looked in. Thank you. That's my question.
Okay, thank you, Representative Anderson and Mr. Chair, both. I do know about this. There's a little bit more to the story. I came to state government because I have the same frustration with bureaucracy as you do, and we've had that conversation several times. I think the other side of the story, and I do agree with you that there are extenuating circumstances here, is that in order for us to get money from the federal government, we are actually required, DOH is required to regulate the administration of vaccines and show evidence that they've checked records of a wide variety of things, including temperature checks in refrigerators. Every single compliance violation I've ever come in contact with was surrounded with extenuating circumstances. And so part of this, and we do commit to, I'll get back with you offline and get more detail, and we'll follow up more, make sure that clinic is in business. But we don't want to give up all the federal funding for all the vaccines in the state by not regulating. And so it's trying to walk that tightrope between meeting federal requirements to get funding, which is kind of what we do every day in Medicaid, and understanding and making sure the providers have what they need. And so I'm on it, and I'll get back to you.
Dr. Scrace, thank you very much for that response. And I certainly understand it's a mighty thin pancake, doesn't have two sides. So I accept that as well. And I wish you the best in your endeavor because, you know, we're just getting down to the most critical of the critical basic needs of young New Mexicans. Mr. Chairman, thank you. That concludes my question.
Thank you, Representative Anderson. Next, we go to Representative Thompson.
Thank you. Thank you, Mr. Chair, and thank you, Nicole and Dr. Scrace, for a great presentation. So when the public health emergency ends and we've kept these people on Medicaid, what's going to happen? Is there going to be a cliff? Is there a plan for what to do with all the people who have been held on because of the emergency?
Sure, Mr. Chair, members of the committee, Representative, there is a plan. There are options for how this could happen. It could be a cliff. It could be a rolling set of notices and disenrollments of this population. CMS has actually indicated that they're going to put out guidance to the states on how they are thinking they're actually going to require us to do this disenrollment. So at this time, we've worked with the team to explore both options. You can imagine that there's not only impacts on the members that are different in both of those sets of circumstances, but because we're a managed care state, there's also financial implications for either of those options. So all of that is listed out actually in the work that we've been doing in looking at the future and unwinding all of this. And right now what we're just waiting for is guidance from CMS that they had told us was going to be out 2 weeks ago, but we are still waiting to see that. So we will make sure to share that with you all as soon as we see what they put out.
Okay, thank you for that. And then when you applied for the EMSA waiver, it's my understanding that 8 other states are eligible to provide for treatments of undocumented people. So I'm just wondering why New Mexico isn't one of those 8.
Sure. Thank you, Mr. Chair and Representative. Our Deputy Secretary, Carrie Armijo, is on the line and worked really closely with me and others on this. So I will, if the folks could open up the line to her in case she wants to chime in. There was a significant cost associated with also expanding this to treatment. And because there was another option available through the HRSA portal, we didn't go into that today, but testing and treatment is available to be covered for uninsured and undocumented individuals through the HRSA portal. And so because that was an available option, we looked at the cost to the state. We decided to look at providers utilizing that option first, but should they run out of funds there, it would be something that we could take under consideration. Carrie, do you want to chime in?
Sure. Good morning, Mr. Chair, Representative Thompson. Can you hear me okay? Just want to double check. Glad to be here with you. Thank you for the question. We did a cost analysis to determine what the fiscal impact would be of covering treatment through the MSA program. It was about $1 million general fund. And as Nicole mentioned, we had other options for that population through the HRSA portal. So we really have focused our efforts on the testing components. And so New Mexico was the first state actually to get the testing approved through the FCRA program, which I think we've talked about with you all. And that program covers testing and testing related services for the uninsured. And we wanted to make sure that service was aligned with what we could offer to undocumented immigrants as well.
Thank you, Carrie. Sorry, Representative Thompson, I just wanted to note that in the slide 14, where we talked about the dollars that have been distributed to New Mexico providers, we do know that New Mexico providers have submitted claims totaling just over $3 million through that HRSA portal. So we do know that it's being used, and we're hoping that it's being used for those services.
Thank you for that. So, and this may, I'm not trying to ruin your reveal party or anything like that, but what is the budget request increase that you're going to ask for when you go in front of LFC, if you're comfortable, even a ballpark or a percentage, if you know that?
Well, we've submitted our budget, and the request statewide was that all departments reduce their budget by 5% because of the significant revenue shortfall. Medicaid got a target of reducing by 3%. And I think DOH was either 3 or 1, something like that, for obvious reasons in the face of the pandemic. So we've submitted a budget that covers that. We've also addressed with you that gap between the dashed green line and the dotted green line, and so a lot of what will affect our budget next year has to do with what happens this year, and 90% of that range is based on whether or not we get an additional federal match or increased FMAP in the first 6 months of 2021. So it's we're all kind of holding our breath. I mean, it's really hard to figure your budget out exactly when it's, plus or minus $150 million. And so we have scenarios for both. So right now we've submitted a budget, and that's being processed. You'll all be happy to come back with some of the details and tell you more about it. I think right now we're in Medicaid. Danny Sandoval, our best CFO in state government, is on the line and texted me that the Medicaid request itself is 44 million additional dollars in Medicaid. So that's a little bit of an up, but we're still 167 million short of our projection, where we're going to be at the end of the year, which is why, $50 million makes a big difference. So,
okay, thank you for
hopefully I
that.
didn't confuse you. Sure.
But that's okay. So in terms of the electronic visit verification, I know that as this has been rolling out, there have been many concerns over connectivity, and we've even heard that today. So how is that working?
So, Mr. Chair and representative members of the committee, Megan Pfeffer is on the line, who has been, I think, helping with that effort. So I'll see if she could add anything additional. This may be one that I want to take back and get you some more information on. I know that on the updates that I've been being provided, folks are still feeling like we're on track to have the implementation go live on time. However, I have not heard any significant concerns about connectivity, although I will tell you at my house, I have those concerns every day on the south side of Santa Fe, so they're probably very valid. So I'll stop and see if Megan has anything to add, but if not, I will make sure to take this one as a follow-up to get back to you on. Megan, are you able to unmute? Great.
Yes, good morning, Mr. Chair and Representative Thompson, members of the committee. We do have a regular report we're monitoring of EVV activity that the MCOs provide us. We've not seen any dips in this report as of late, but we can get some additional information for you to show you that data.
Okay, that would be great. Thank you, Mr. Chair. And then I'm going to go a little bit maybe where I shouldn't in terms of the anti-science swell that's going on out there. So I have a couple of questions around that. So, on Facebook, on Twitter, on everywhere, there's this idea that if hospitals say that someone has COVID, they get all this money. So could you just in a brief time talk about what the truth is around that?
Mr. Chair and Representative Thompson, thanks for the opportunity. I'm like the science guy these days on COVID, and we deal with a lot of it. We just finished a 20-page response to a series of questions from 12 senators that challenged a lot of the way we were doing things. When a hospital bills for a patient and says they have COVID and they do not, that would be fraud. The patient would not be registered in our system because we only count cases when they have a positive COVID test that comes by a direct electronic feed from the laboratory. And so, if let's just say you and I both got COVID today and you had one test and I had 10 and all 11 tests were positive, you would be counted as one and I would be counted as one. So a hospital actually puts its livelihood and its ability to stay in existence at jeopardy were they to bill a false diagnosis for a patient. And frankly, I don't believe that that's going on.
Oh, thank you.
And at least in Medicaid, I forgot this. This is the most important part. In Medicaid, when we increased hospital rates, we didn't increase them just for COVID patients. We increased them across the board. So substantial increase in ICU, because that was our most critical resource in March. We did not want to have New Mexicans having to share ventilators with other people. And so that worked. And we've expanded ICU capacity, more than doubled it. Fortunately, we haven't had to use it all. And so I think there are a lot of myths about COVID, and I believe that's one of them. Okay. And we decided, because we did so much work, it was like a week's worth of work to answer these dozens of questions. We're going to start a special frequently asked questions, which is a euphemism for urban myths about COVID. And we'll get that up with a link out from the medical advisory team on the website, and you can go in, and a lot of these things you see in the newspaper have been addressed there and will continue to do so.
Wonderful. Thank you, Mr. Chair, and thank you. And my last question is, there's been a small but very vocal group of anti-vaxxers. And I'm afraid, very, very afraid, that this whole science denier business is going to make that grow. So is there any data out there there's so many factors that are affecting whether our kids are getting vaccinated. Is that playing a part yet? How much of a part do you expect it to play? Are you ever going to know?
Yeah, Mr. Chair and Representative Thompson, it's like a really important question. I think I got asked that at a press conference. Do you anticipate resistance to the vaccine? Well, number one, it depends on how effective it is and the side effects. If all these vaccines come out and they're 20% effective and they're horrible side effects, well, I'm going to have resistance to the vaccine, and I keep up with every single vaccine now. I'll probably be, I may end up being required to have the vaccine to work as a physician at some point, like I am with influenza, although there is an alternative out where you just wear a mask, which now I'm used to. So there's that. I think we just don't have any data. I think the other thing is New Mexico will do an independent evaluation of the data coming out from each of these 6 vaccines and determine whether it's safe for New Mexicans. To get herd immunity, we need, 70 to 85% of people, nobody has an exact number, need to be vaccinated or have had the disease. And that does leave room for an anti-vaccination contingent. There are no plans to require a COVID vaccine for return to school. So hopefully that won't create a big uproar. And so I think we're on it. I think it's all going to come down to, like any purchase we make of anything, what does it get me and what's the risk of doing it? And we just won't know that till we get, hopefully, all the way through the phase 3 trials that are testing this on Americans to see what kind of immunity is developed. So I could talk, as probably for well into the afternoon on this topic, but I think that we're just dealing with it like we would any other vaccine in that regard.
Okay, that's all I have. Thank you so much for your answers. And I really do want to thank all of you I know you've been working your tails off and it shows, and a lot of us appreciate it. So thank you so much.
Thank you, Representative. I am going to go to Senator Rodriguez for a quick follow-up question.
Thank you, Mr. Chairman. I will be fast, and thank you, Dr. Strace and Nicole and all your staff. You do so much work, my goodness. And also having to comply with all these regulations and so on, and it's just an enormous amount of work. But I just have a quick question maybe for Nicole. If you can just clarify something quickly for me and Nicole, on one of your slides, and I went, tried to get through it, but I went a little too fast. You mentioned that 82% were enrolled in, did you say managed care? Because if 56% of children are enrolled in Medicaid, then I'm a little confused. And then you mentioned 43% are children, but I figured they were probably part of the managed care. Can you just clarify quickly so I can follow it as you're continuing? Thank you.
Sure, Mr. Chair, members of the committee, and Representative Rodriguez, we have 82% of all of the individuals who are in the Medicaid program are enrolled in a managed care organization. The percentage you heard me quote about children, and I did move through that slide really fast, so I'm sorry. I'm pulling it back up so I can give you exact numbers, but about 54% of all kids in the state of New Mexico are covered by Medicaid. So if you wanted to do an average there, you could say that 80% of that 54% were probably in a managed care organization.
I see.
That helps.
Nicole, Mr. Chairman, Nicole, the 43% you mentioned are children. Did I hear that correctly? I was not sure what the 43% was.
Sure. Let me pull that slide back up.
Yeah. You might want to refer the group to the actual slide so we're all literally on the same page.
Yeah, I'm pulling it back up.
Thank you. And I can pull it up here on the WebEx. So otherwise,
okay, let me pull it up so we can all look at the same numbers. Hopefully I can share again. Okay.
Thank you, Dr. Sprice. There's the slide with the number.
Am I on the, I'm not on the right slide here though. Hold on.
It's slide 22.
Yes, you were just a moment ago.
Nicole, if you just type 22 and enter, you'll go right to it.
It's in like a, sorry, it's in a weird presentation format in WebEx. So thank you for the number reference, Madam Chair. There we go. Okay. So, so there we go. So 40% of all New Mexicans are enrolled in Medicaid. That's about 870,000 individuals. We expect that to grow to about 885 by June of next year. 82% of all of those members are enrolled in a managed care organization. 43% of all of our beneficiaries are children. And what that equates to when you look at the population of the state is that 56% of all New Mexican children are enrolled in Medicaid. And the number that is even more stunning and actually puts us at the very top of the list across the country is that 72% of all births in New Mexico are covered by Medicaid.
I see. Okay. Thank you. Thank you so much for explaining that. And I will be able to get a copy of this handout, and I think we have it emailed already. So thank you so much, Nicole, Mr. Grace, and Mr. Chairman. That's all I have.
Okay, I notice now that we have a number of other questions, so I'm going to say you all get one question from here on out. I apologize, but all of a sudden people are asking questions at the end of the time available. So Senator Lopez, you're next.
Thank you, Mr. Chairman, and hello, everybody. First of all, I'd like to say thank you, Grace, to you and your team. You're doing a wonderful job, and I know it's hard for all the different questions that come in, but the information that you are giving is exemplary, so thank you. I just have one question, Mr. Chairman, and I think it goes back to part of the earlier presentation. It mentioned that there is no charge for those who are presenting themselves to be tested on COVID. Is that correct, what I heard?
Yes.
Yes?
Yes.
Oh, sorry. Yes, Mr. Chair. As the committee, Senator Lopez, that's correct. We're both nodding at you. I'm sorry.
Okay. And the only reason why I asked this, Mr. Chairman, is because, and the only reason why I asked this question is due to the fact that I was watching TV the other night, and they mentioned, of course, that testing is still taking place, but to please bring your insurance card. So for me, if persons are out there thinking that, if they have symptoms or whichever, asymptomatic, as we know the process, but if the news media is mentioning that you to bring your insurance card, I think there's some misinformation there. Just wanted to bring that to the attention, because if we're saying here that there's no charge, and yet the media is saying that to please bring your insurance card, I think there's a bit of communication issue. That's all, Mr. Chairman. Thank you.
Mr. Chair, members of the committee, Senator Lopez, I'll start, and if Dr. Grace, you want to chime in, feel free. It is accurate to say that there is no charge to individuals for getting a test. However, we still do need to try to bill insurance wherever possible for the administration of those tests. So we do need to gather information as to whether or not those members have Medicaid, private insurance, or any other source of coverage. Otherwise, those tests would end up resulting in dollars that we would expend through funds that DOH has available, but those are limited, or they would result potentially in uncompensated care for those providers. So insurance companies, public and private, are required to cover the tests and not pass those charges on to the individuals that they cover. So the test should be free to members, but you do need to bring your insurance information. Does that help clarify?
I guess, excuse me, sorry. I guess that kind of adds some clarification. So there's no charge for us if we go in to get tested because the insurance will cover it. But essentially, are we saying then that those who don't have insurance coverage have to pay?
No,
Mr.
and,
Chair, go ahead.
Mr. Chair and Senator Lopez, Great question. I think what you're pointing out is when we tell people on television to bring their insurance card, people without insurance might assume that they're not covered and can't get the test. And so we will work on clarifying that message. It comes out of the governor's mouth at almost every press conference that everyone can be tested and everyone will be covered. But I agree with you that that can be misleading in the context of be sure to bring your insurance card in. But the fact is that anybody can go and get tested and no one has to pay out of pocket.
Okay, and if just some clarification, because it was on KOAT and KRQE that I heard that mentioned during the news, during their news when they're mentioning this. And for persons in my zip code area, as you know, we're the hot spot. We have over 1,000 people here who have been positive tested for COVID. So I had a few folks in my neighborhood as I walked that asked, well, I thought we didn't have to pay. So that was the question that was asked of me actually last night. So thank you. But if it could be clarified, I think that would help also. Thank you. Thank you, Mr. Chairman.
Thank you, Senator. Representative Cadena, you get a question.
Thank you, Mr. Chair. And just as I named earlier, my children are now in school, one Zooming, and I politely asked the other one to pause on her homework so I could ask a question, but my video is not available currently. I wanted to follow up on some questions asked by Representative Thompson. I had was wondering the same, how are we going to pay for this? And I appreciate all the thoughtfulness and planning you all are doing, Secretary Grace and Director Como, in keeping track of these rising numbers and enrollment numbers, and also doing everything you can within your capacity to plan for what happens moving forward. I definitely heard the comment that CMS is a little bit delayed on their guidance related to what's going to happen to these new enrolled members. I just wanted to take accountability as a legislator in our body and then ask my question. I know that in the special session, there was a lot of debate about what was happening between LFC numbers and DFA numbers in our budgets, talking about swaps, which in my mind, in effect, were sweeps. And if I remember accurately at the time, it seemed that we swept $75 million for Medicaid plus 3% sanding, which would have added over 100 million. Yet I continue to hear us say, as a body and others, that Medicaid was left whole. For me, there's a bit of a disconnect there, and I appreciate that you all are getting ready for LFC again. And my question really is, I want to hold my responsibilities as a legislator. If I imagine there's no way around it, as has been named, we are going to see significant shortfalls in Medicaid dollars in coming years. And instead of leaving that on the shoulders of you to make hard decisions and figure out how to try to hold some semblance of a healthcare system with a lack of funding that we really need, what would be helpful from us in the body that are paying attention, that have some sense of what your role and responsibilities are, the incredible job you're doing, and the real budget questions that are looming? Is there anything that you might ask of us as we get ready for LFC in a couple of weeks, and certainly get ready for the long session? Thank you, Mr. Chair.
Mr. Chair and Representative Cadena, great questions. Nicole and I have been losing a lot of sleep about that this summer, sleeping a little better right now. I mean, the tricky part of it is that everything you said was true. There was a sweep. There is a 3% cut. We were kept whole, and the way that people figured the keeping whole part was comparing last year's budget to this year's budget. I think we'd asked for and received very generously from you all 8 or 9% increase. And so the thinking was, if we have a lot of room in that 8 or 9% increase to bring that back down to level. And so we're working on this night and day. And I think that we're educating everybody about the details of the budget. We're looking at provider rates again because of this. But in the end, the tricky part for us, and what we really struggle with, is this idea that we might get another $150 million or we might not. And I think the sense across all of state government, including LFC staff on this one, is let's see what happens. And that drives us a little nutty because we're really anxious to intervene if we need to intervene and do things if we need to do them. But I think, it's $150 million is a lot of money, and it covers almost all of our projected loss. So one, everything you said is true. Two, we will be completely transparent with you as we get more and more information about those expenses as they roll in. Our hunch is the 6.2% increase isn't enough. And if I had a magic wand and could fix one thing right now, like I could only pick one thing to fix, it really wouldn't be the state general fund contribution to our budget. We'd be getting the federal government to understand that the 6.2% increase that we love just isn't enough to deal with the cost of the pandemic. And so we can talk more about it offline, but right now we know that in Medicaid, we're going to have a $167 million shortfall, or $170 million sorry, I got this backwards. This year, a $70 million shortfall, and if things keep going, bigger in 2022. And so I guess I'm comfortable now that we've talked it all out with LFC and DFA of waiting a little bit longer. It's just that the longer we wait, the tougher the changes will have to be if those federal funds don't come through. So if you could do one thing, because we appreciate your taking accountability, it would be to call your congressional delegates and let them know how important and even more of an FMAP will be. We also think, and we don't know really at all, but most people think that the election will have some effect on all of this. And of course, it depends on the election comes out, and it depends on what happens in the winter. And I don't think they're going to stop federal funding if the pandemic flares up in the winter. But I would say, let your congressional delegation know that the federal FMAP increase is the best way to take care of low-income New Mexicans. Anything to add, Nicole?
Sure, Mr. Chair, members of the committee, Representative Cadena. I think, like Dr. Scray said, those are really critical questions and the ones that have certainly been keeping me up at night. Just to let you all know, because, we have those concerns, like Dr. Scray said about, what happens if we do wait longer. If the money doesn't come, we want to be prepared. We're hopeful it will. But if it doesn't, we've been working really hard. We've presented options to DFA and LFC to outline what measures we may have to take and what options there would be for consideration if we did have to start making changes to the program to accommodate that shortfall. We have a really good working document that allows you to make those changes and see what it would take to balance our budget. So I know we're presenting to LFC here pretty soon, and expect to be able to get you all more information on that front so that you can see what it would take should we need to balance to that larger shortfall in 22 that Dr. Scrace already mentioned.
Okay, thank you. I think we're going to have to go on then to Representative Roybal Caballero for her one question. I would remind the members who've already asked their question, don't forget to take your hand down on the participant list so we can keep track. Representative Roybal Caballero.
Thank you, Mr. Chair, and thank you, Secretary, and nice to see you, Ms. Kamal. I hope I pronounced that correctly. Thank you very much. It's always a pleasure to see you all. I wanted to frame this carefully here. There's been a large part of our communities, our poor and working poor communities, that have traditionally been hesitant to tap into Medicaid health benefits and other benefits, other assistant benefits, either due to cultural factors or due to fear of these systems, and particularly their immigration status or any other stigmas or stereotypes associated with receiving these benefits. And of course, this goes against the common notion that poor people choose to remain poor so they can get these benefits, but that's not been my experience as a community organizer, and it's not been a widespread experience. So in dispelling that, I did want to ask you this question, and it's in consideration of knowing that we rely heavily on census data, which we know is not always the most reliable due to undercounts, traditional historical undercounts that we've had. but do you have a way to determine the number of underserved that perhaps as a community and doing our community organizing that we can kind of, not that we have all the resources to be serving, but certainly if there are underserved and we can work towards preventing health issues by addressing access to health care for as many as possible. I wish we had health care for all. This is where I'm leaning. And before you answer, I want to thank Senator Lopez real quickly, because I've had these similar questions from constituents, and I just want to make sure the Secretary, when you clarify with the media reference to paying for the COVID testing, to please do so with the Spanish-speaking media, because my calls to the constituents have all been Spanish-speaking members of the community who are concerned about getting tested because they don't have the money to pay. So I'm sorry to sidetrack it there, but I didn't want to forget that thought. So back to the question, Mr. Secretary, do you have a way of gauging, a way to determine the number of underserved that we in our populations?
Very briefly, Mr. Chair and Representative, we have a pretty extensive presentation coming up on, how many uninsured we have in New Mexico. The tricky, we can measure that. In order to measure the term underserved, you need a really specific definition. But often when we talk about that, we talk about people who would meet the requirements for Medicaid or SNAP or other things based on income, but don't meet the requirements based on other criteria. And so I think we're going to get into that a little bit more today. And then if you let us know if we didn't address that question, and Abuko Estrada and others will circle back with you.
Thank you. And sorry, Mr. Secretary and Mr. Chair, I failed to look at the next item on the agenda very well. So I thank you very much, Mr. Secretary, and thank you, Mr. Chair. Thank you.
Thank you, Representative. And while I'm thinking about it, we are also going to have a full presentation later this fall on vaccinations. And so that issue hopefully will be thoroughly aired at that session as well. Representative Ferrari, you're our final speaker.
Thank you, Mr. Chair, and thank you, Dr. Scrace and Director Camo. As you're trying so hard to make ends meet and provide all of this great care and to keep our providers where they can afford to stay in business and be the providers, when we were talking about the budget, it reminded me about how important it is that as families are trying to make ends meet, that sometimes they skip out on having healthy food or even being able to put food on the table. And I hope that, Dr. Scrace, in your budget, you are able to help our food banks so that they can be there as we see more people, coming close to foreclosures or being moved out of their homes or their apartments and rentals, that, if we can provide more through our food banks, that might help them, be sure to have the other means, plus the nutrition to keep up their immune system and be able to fight off any, diseases or, the virus. So Dr. Scrace, I was wondering if that's one of your priorities too.
Mr. Chair and Representative, great question. We are, we've learned a lot about food because it turns out HSD is responsible for food and shelter during an emergency like a pandemic. And so, as Nicole mentioned, Kathy Slater office stepped up, and we're proud of the fact we've delivered 2.2 million pounds of food. SNAP has been an unbelievable vehicle for delivering hundreds of millions of dollars of extra money into the pockets of low-income families to make sure they have adequate nutrition during the pandemic. Health secretaries are having extensive conversations along with PED about what economies of scale can we bring together in all of our different food programs to figure out the best way to deliver. And of course, there's absolutely no way state government could ever hope to meet the necessary nutritional health food needs of our population without the local food banks. They do an amazing job. They provide a huge percentage of the food for the folks who can't afford to buy it. And we get that that's part of our mission as well. I can't give you an exact number about what's in the budget we submitted, but we can get back to you on that one.
Okay, thank you, Dr. Grace. Thank you, Mr. Chair.
Members of the committee, Representative Ferrari, our ISD director, Carmela Martinez, is on and I think may have a note about this and work to support food banks permanently. Carm, did you want to unmute? I know we're running out of time.
No problem. Good morning. This is Carmela Martinez, the chair and representatives. We are actively working on making sure that the efforts that Secretary Grace just mentioned around the ESF and the emergency services specific to supporting food banks and their distribution. We're actively working on inheriting that contract so we can leverage that buying power, but offer the warehouse services, the delivery, and the purchasing so that we can make sure we streamline and make sure that there is the appropriate amount of food to all state areas as needed. So that will no longer be just an emergency function. We will continue that as a permanent function, and ISD will support that effort ongoing. So thank you for that.
Thank you. Appreciate it.
Good. Thank you, Representative Ferrari, and thank you, Dr. Grace and Nicole. I just wanted to add one thing. I don't have any questions, but I want to alert you to something. I was invited to a virtual meeting earlier this week of the Behavioral Providers Association. They are very concerned that they did not receive any of the benefit of the CARES money. They feel like some of them are being left out of the efforts to prepare for this surge that we anticipate in the need for behavioral health care because of the pandemic. And they're very concerned that the MCOs are utilizing primary care providers to provide medication, but that it's not really including them in providing psychotherapy, counseling, any of the other things. And they brought this up to Dr. Bowen, so I'm not going behind his back, but this is a concern that they have, that while the primary care network may have been taken care of with the CARES money, they weren't, and some of them are in pretty desperate financial shape as a result.
So, Mr. Chair, if I may turn that into a question and give you an answer, would that be okay?
That would be great.
Okay. So this is really interesting. This keeps me up at night too, and you can help me with this. But there is a provider relief fund, and CMS is begging providers to apply for it, and like 1% of providers applied for it. We've sent out numerous communications. Please, we're begging you, apply. We've sent it out to Primary Care Association, Medical Society, Behavioral Health Association, and others. Apply. There's money there, and it can help. You know, we gave a generous increase to behavioral health providers, substantial above rate, non-behavioral health providers last fall on October 1st, and we said the lawsuits, we're doing an awful lot, but there is money there. They just need to apply for it, and if they lack information, they can go to our website or give us a call. We're happy to help. But their association should be encouraging them, and you should encourage them as well to apply. Nicole, I know they've extended the deadline twice. Is it still open?
They have, Mr. Chair, representatives, and Dr. Grace, or members of the committee, they have extended it numerous times. There were some issues in the methodology, but now all providers are eligible to go in until September 30th, and they really, really should apply no matter what. Even if they think they're not eligible, they likely are, and they should apply for those distributions at this point. These are not loans. They don't have to be paid back. These are actual distributions from that provider relief fund, and behavioral health providers are eligible. They are on the list. So I did hear about this request, and so I'm happy to work with Dr. Bowen to meet with you next week and give you more information if that's helpful. But we will, and the September 13th deadline is just what I want to make sure we reiterate. So providers have until September 13th. They go to hrsa.gov, hrsa.gov, and they can apply for provider relief there. There's tons of information for them, lots of infographics to walk them through it.
And I think another idea, Mr. Chair and Nicole, and this is for the team that's listening, let's get a press release out the next few days and maybe get some quotes from the various provider organizations, sort of in a joint one last chance message out there. So to get the word out even further to Senator Ortiz-Pino's point. And I think the media has been by the way, the media has been a great partner with us throughout the entire pandemic and getting the word out about Medicaid and SNAP and other benefits. And this would be a good one that would help New Mexicans also.
Well, very good. Thank you all for the presentation. Terrific information. I'm sorry we're cutting things short. We're jamming so much into our reduced schedule this year. So members, we'll now go to, we're about a half hour behind, but we will go now to extending healthcare coverage to New Mexico's uninsured. And we have Jessica Banthen, a senior fellow at the Health Policy Center with the Urban Institute, and Ebuko Estrada, who's the Coverage Innovation Officer at the Medical Assistance Division of the Human Services Department. So who's going to go first?
So, Mr. Chair, members of the committee, Ebuko, I am so fortunate that we were able to bring him onto the Medicaid team. So I'm going to do the opening slide and turn it over to him. Then he'll transition to our colleagues at the Urban Institute, and then I think he's going to close us up. So, Ebuko, if you could share slides, I'll go very quick. I know we're very over.
And I wish I could, Nicole, but it's not letting me share the content right now. But
okay. I probably have the presentation too, so give me 1 second. Pull it up. If I, hopefully, Andrea, if I still have the ability to.
You should have presenter privileges now.
Okay, thank you. It looks like that's working now, Nicole.
Great.
Can you see my screen?
Yes.
Okay, perfect.
Okay, so thank you again for another opportunity, and luckily you all will be spared my disappearing voice on this one, and Ebuko will be the one to lead you through this presentation in collaboration with Urban Institute. So Ebuko, if you can advance, please. For sake of time, I'm going to pass our mission and goals. We just talked to you about them, and the next slide as well, our agency priorities. Move forward one more. There we go. Okay, so just to set the context for you all, in the 2019 legislative session, we were charged with evaluating coverage options. This was after the Medicaid buy-in proposal was brought to you all, and in looking at that option, we came to, I think, conclusions coming out of that session that while it may be a good option for increasing coverage, it was also going to come with a significant price tag. And so we were therefore asked to look at additional options. The goals of this study were to address the remaining uninsured population, so figure out how we could increase coverage across the board, and then also how we could improve affordability. So the first phase of the study we completed with Urban in December of 2019, and Ebuko and Dr. Scrace reported out to you all at that time. That first phase was to basically do an assessment of the remaining uninsured and see who it was that we were trying to cover with these additional coverage options. The second phase of the study that we'll be presenting today is an analysis of those additional options and also an update on that assessment of the remaining uninsured. This is coming to you all pretty close to the time that it's coming to us because the population has changed so drastically as a result of the public health emergency. The Urban Institute has worked very quickly to adjust their study to account for all of the changes in our population since the public health emergency began. So really today, just looking to present you all the information and give you some early education on it, and then likely many more conversations to come on this, what option we may recommend and how that option may be financed. But those are conversations I believe that we'll have in the future. So with that, Buko, I'll turn it to you to start us out.
Thank you, Nicole. And Mr. Chair, members of the committee, it's an honor to be in front of you again. I know oftentimes I am sitting between you and your lunch hour, and so I apologize for that again. But hopefully I'll give you a little bit of food for thought as we talk today about reaching uninsured New Mexicans and how we can make coverage more affordable. I think it's always helpful when we're talking about these issues to refresh our thinking and our knowledge around what health coverage options are available in New Mexico. And so I just wanted to give you a high-level overview of all of the options that we'll sort of be referencing today. First and foremost, there's is the Medicaid and CHIP, which is, you all know very well as a public health insurance program providing no-cost care to New Mexicans, including children, pregnant women, seniors, people with disabilities, and adults with low incomes. There's also the well-known program of Medicare, which is mainly for people over 65 or younger if you happen to have a disability. And then there's the exchange, which in New Mexico is known as Be Well NM. And I think it's always helpful to think of the exchange as the marketplace, where a New Mexican goes to buy private insurance when they don't have Medicaid, Medicare, or coverage through their job. It's also the place they go in order to get the federal subsidies that help them pay for that coverage. And then there's the employer-sponsored insurance, which is just very simply coverage offered through one's job. And then I just wanted to mention some other programs that are interrelated with a lot of these in terms of helping provide access to medical services. And that's the Indian Health Services and the Veteran Affairs, among other programs. And Mr. Chair, members of the committee, I think it's also helpful to find some key terms that'll be useful today for the rest of the presentation. First, there is the federal poverty level, which is really very simply the measurement that we use to talk about the minimum amount that is needed for New Mexicans and their families to be able to pay for essentials. It's also used to establish thresholds in Medicaid, SNAP, as well as for tax credits that are used to help pay for coverage under the Affordable Care Act. Then there's your premium, which I think most everyone's familiar with, whether it's in the healthcare context or even auto insurance or other types of insurance. It's simply your monthly payment that you pay to maintain your coverage. In this context, that would be healthcare. In terms of out-of-pocket costs, or some individuals refer to this as cost sharing, this is the payments that you make as a New Mexican when you go to use services. And so you'll probably know the terms like co-pays, co-insurance, and deductibles. And then premium tax credits. When we're talking about this, these are tax credits available under the Affordable Care Act that are used to offset how much individual pays on their monthly premium. They are income-based for individuals between 0 and 400% of the federal poverty level. And as I mentioned earlier, the place where you go to get them is through our exchange marketplace. Additionally, there's also cost-sharing reductions, or we might refer to them as cost-sharing subsidies. And when we're talking about this, we're talking about a program for lower income individuals that helps lower their out-of-pocket costs by reducing things like the co-pays, deductibles, and co-insurance. And so on slide 8 here, as we're talking about some of these terms, I know federal poverty level it can be very abstract. And so I wanted to give you a clear example of what some of the various poverty levels look like in terms of, monthly dollars for a few different households. And so, for example, here, if we take a look at the row that's for 175% FPL, for a two-person household, what this is showing is that at that level of the federal poverty level, that household is making roughly around $2,514 per month in gross income. And this is helpful in understanding how the Affordable Care Act premium assistance works. And so under the ACA, individuals are given tax credits that is based on their income when they're between 0 and 400% of the federal poverty level and they don't qualify for another coverage program. These tax credits are administered on a sliding scale based on that income. And the way it works under the Affordable Care Act is the law says we're going to require you to pay a certain percentage of your annual income towards premiums, and then the tax credits will cover the rest and make up the difference between what you pay and what the full premium is. And so, taking a look at this table and some examples, let's take a look at the row that says 151 to 200% of the FPL level. What this is saying is, for an individual at 200% of the federal poverty level, the Affordable Care Act is going to require them to contribute 6.49% of their annual income towards paying for what's known as a silver plan. And that translates to about roughly $97 per month. And so the next slide, slide 10, really just shows you that in a real world example. So we're looking here at a 2-adult household at 175% of the federal poverty level. That puts them at an annual income of roughly $30,170 per year, or the $2,514 per month that we discussed. For a family like this in New Mexico, as an example, they might see a family plan that costs around $611 per month. Well, as we just mentioned, the federal government says we are going to require you to pay a certain percentage towards this amount, and we'll cover the rest with the tax credit. So in this case, at this FPL level, under the current law, this family would be required to pay 5.3% of their annual income in order to buy the benchmark silver plan in New Mexico. And so what happens there is, that translates to $133 per month that the family would be required to pay. And then the federal government pays the remaining, which is $478 to contribute to the full total of the $611 per month premium. Mr. Chair and members of the committee, it's also helpful to understand in the Affordable Care Act that there are different levels of plans that New Mexicans can choose, and they're based on metal tiers, or what some might refer to as actuarial values. And these are helpful to know about because they're useful when applying the tax credits, because as I mentioned, the tax credits are based on income as well, but the amount is also based on what's known as the benchmark silver plan, which is the second lowest cost silver plan in our market. It's also helpful to know these values for knowing about cost sharing, because as we move, from bronze to platinum, you see that the plan ends up covering more for individuals, while the consumer pays less in terms of out-of-pocket costs. However, I think it's helpful to sort of sit here and explain a little bit about the metal tiers. And so, with the bronze plan, what we're saying here is that on average, this plan would cover about 60% of the costs, and the consumer would cover about 40%. These plans typically have really high deductibles and out-of-pocket costs, but their premiums are a little bit on the cheaper side. And then as we move across the tiers over to platinum, the plans will end up covering roughly around 90% of the costs, with the consumer covering 10%, but those plans tend to have higher premiums on a monthly basis. And there's the only real difference in what the plan covers in terms of benefits is all of these plans have to cover a set of what's known as essential health benefits. But the difference comes in these percentages and on average how much the plan covers and how much you end up paying in your monthly premium. And so again, as we're talking about these metal tiers and how much the plan covers, it's helpful to also understand the Affordable Care Act's cost sharing assistance. And so this is a program under the ACA where individuals and families under 250% of the federal poverty level can qualify for a varying level of cost sharing reductions based on their income if they enroll in a silver plan. And those cost sharing reductions will help lower their copays, deductibles, and coinsurance. And so just as an example there, let's take a look at the middle, 151 to 200% federal poverty level. A family in this income range buying a silver plan is still getting a silver plan, but the cost sharing reductions help bump up the value of that plan to cover more for that family. And so even though they're getting a silver plan, it ends up being a value of something that looks more like a gold or even a platinum plan, depending on their income. And so here, Mr. Chair and members of the committee, is sort of an example of how that cost sharing reduction program might work. And on slide 13 here, we're using the example of the lowest cost silver plan in New Mexico in most areas of the state. I do want to note that things like the out-of-pocket max, deductibles, primary care visit costs, and generic med copays are areas where insurance companies compete. And so these values won't necessarily be uniform across the marketplace, but the plans do have to meet the overall value that we just talked about, whether it's covering 60, 70, or 80% of the overall costs on average. And so just taking a look at this example, the lowest cost silver plan there at the bottom, if a family's not getting any cost sharing reductions at all, they could see an out-of-pocket maximum of around $8,500 per person and an annual deductible of around $6,000 per person. But if we take you all the way up to the top there, and let's say the family is a lower income and they're getting the most cost-sharing reductions possible, they go from that high out-of-pocket maximum and deductible to potentially something that might look like a $1,500 per person out-of-pocket max with a $0 deductible and maybe some $0 copays in certain areas. And so with that, Mr. Chair and members of the committee, before I turn it over to the Urban Institute, I do want to give you a little bit of a high-level overview of the options that we had them look at under the coverage affordability study. and Mr. Chair, members of the committee, I know where all of you are, and I know that your hearts are always there for New Mexicans and doing what's right for them and trying to improve, affordability of healthcare and access to coverage. And so, I think you're always thinking about what it looks like for your constituents. And so I thought it'd be helpful to ground us in that thinking with a story of, a fictional constituent. Here we have, the family of Ezekiel and Sophia Flores. Ezekiel's self-employed and Sophia's going to school for her master's degree. They have an income of about 175% of the federal poverty level, which, as we talked about earlier, is roughly about $2,514 per month. And they're looking at the exchange. They would like to buy health insurance, but under the current ACA, their required contribution for a silver plan would be around $133 per month. It's a little bit too expensive for them, especially with Sophia's school expenses. So they also take a look at the bronze plans because those are a little bit cheaper, but they see that they have really high out-of-pocket costs. And so they decide to not buy any coverage and remain uninsured, thinking that they can pay for the doctor's visits and medications out of pocket if they happen to come up. But during the year, Sophia develops a serious case of asthma that requires regular doctor's visits and access to an expensive inhaler. I think this is an example of a family that you all might know and the struggles that they face with deciding, how to put food on their table, pay for shelter, while also paying for healthcare coverage. And that's the main basis of doing the study, and that's our focus. Additionally, I also want to talk a little bit about individuals who don't qualify for assistance from the federal government and have to pay the full price for their health insurance coverage through the exchange. And so here we have another potential constituent. All right, this is Nia, who's making roughly $54,230 per year, which translates to about 425% of the federal poverty level. Like I said, she doesn't qualify for any premium tax credits. She doesn't qualify for the cost-sharing reduction program that would help lower her co-pays, deductibles, and co-insurance. And so she'd have to take on the full costs of the monthly premium herself and pay some of those high out-of-pocket costs. And in this case, her monthly premium would be the full price of around $326 per month. And so in order to tackle affordability and help boost enrollment for New Mexicans, we had the Urban Institute look at several options that we talked to you all about last November. And during that time, we talked to you about having the Urban Institute model a range of enhanced premium and cost-sharing assistance scenarios, taking a look at the basic health program, as well as taking a look at what a reinsurance program would look like in New Mexico. And I'll pause here to say that, in terms of the reinsurance program, we were underwhelmed and we saw that it really did not provide the benefits of boosting coverage and improving affordability that we thought that it might. And so we're not going to focus too much on the reinsurance program here today, but you'll just know that it is something that we took a look at and decided to not have Urban Institute do much in terms of further study. And so, as I mentioned, one of the first options that we had the Urban Institute look at was a range of scenarios that would enhance the premium assistance and the cost-sharing assistance under the Affordable Care Act. And so when I say enhance, what I mean here is we're taking the structure that's available under the ACA currently, and we would be layering on additional assistance at the state level, whether that's premiums or additional cost-sharing assistance. And we would still target on those low and middle income New Mexicans who are between 0 and 400% of the federal poverty level by directly lowering their costs for their subsidized coverage. An added benefit of doing this is that we would boost enrollment and we would attract more individuals into the marketplace, many of whom are healthier individuals, and we would indirectly lower the premiums for even unsubsidized individuals. We also had the Urban Institute take a look at the basic health program. And very simply, this is an optional program under the Affordable Care Act where the state would offer a public coverage plan focused on individuals under 200% of the federal poverty level. It has been successful in New York and Minnesota with reducing things like premiums and out-of-pocket costs and giving folks more benefits. But it does come with some trade-offs, and I think that there are some concerns about the program, reducing the marketplace enrollment in New Mexico, reducing provider rates, especially during a pandemic. And the current federal rules that are in place really make the program challenging to finance. And so with that, I will take a few minutes to get Jessica's slides up and have Urban give you an overview of the results.
Great. So this is Jessica Banff, and I'm going to try and share my slides. Okay. Good morning, Mr. Chair and members of the committee. Let's see. I have to make sure I can see you. Okay. So I'm speaking this morning on updated estimates of the uninsured in New Mexico and healthcare reform options to improve affordability of marketplace coverage. My presentation is based on work with colleagues whose names are listed here. We're from the Urban Institute. I wanted to mention that the Urban Institute is a trusted source.
We don't see your screen yet.
We're still not seeing anything, Jessica. Sorry.
Yeah, it's black.
Nancy, can you help out somehow?
How about that?
Trying to figure it out.
I just clicked on something.
Not yet.
And Mr. Chair, members of the committee, if I'm able to get the presenter access back, I have them pulled up and can try that way if that works.
Yeah, let's try that.
Can you all see the slides now?
Yes, I can.
Yes.
Okay, Jessica, I can help control them if that works.
Great. Okay, thank you. Go. So I'm talking about updated estimates of the uninsured in New Mexico, and we're from the Urban Institute. Yeah, you can go to second slide. Yeah. So the Urban Institute is a trusted source for unbiased authoritative insights that inform choices about the well-being of people and places in the United States. We are a nonprofit research organization that believes decisions shaped by facts and evidence have the power to improve public policy and practice, strengthen communities, and transform people's lives for the better. We're associated with the Health Policy Center at Urban Institute, which has a long history of health policy simulation work, including extensive experience working with state and national legislatures. And then just a word about myself. I'm recently arrived at the Urban Institute after having spent 28 years in the federal government. Most recently, I worked at the Congressional Budget Office, which is an agency of the U.S. Congress. I was Deputy Director for Health, Retirement, and Long-Term Analyses there. Our results today are based on the Urban Institute's Health Insurance Policy Simulation Model, HIPSIM for short. This is a detailed microsimulation model of the healthcare system designed to estimate cost and coverage effects of proposed policy options. HIPSIM is based on 2 years of data from the American Community Survey, which is fielded by the U.S. Census Bureau. This provides a large representative sample of families that is large enough for us to produce reliable estimates for states and even smaller regions. One of our most notable works in health reform simulation, we used an earlier version of the HIPSIM model, and we worked with the state of Massachusetts. That work yielded a roadmap for their landmark 2006 healthcare reform legislation that expanded coverage and created a subsidized private insurance market for low-income residents, which was a model for the Affordable Care Act. Most recently, HIPSIM itself has been used in many analyses of the Affordable Care Act and proposed alternatives, including studies of Medicaid expansion, ACA repeal and replace proposals, single payer, and other universal coverage proposals. Next slide. So the ACA improved coverage, access, and affordability, but of course gaps remain. We estimate that in 2020, in New Mexico, there are about 214,000 uninsured people. And you can see in this pie chart, the blue half, roughly a little more than half of those people are in fact eligible for Medicaid or CHIP, or they're eligible for premium tax credits in the marketplace, but they've chosen not to enroll in those programs. The other half, roughly, are people who are ineligible for public subsidies at this time, either because their incomes are too high, they may have what is deemed an affordable offer through their employer, or they're ineligible because of their immigration status. The focus of my presentation today, however, is on the 56,000 New Mexican residents who are eligible for premium tax credits in the marketplace but are not enrolled. Next slide. So other states have improved marketplace affordability. Several states have implemented policies. For example, California, Massachusetts, and Vermont have implemented premium tax subsidy enhancements. They've made the premium subsidies more generous and reduced monthly premium payments. Also, New York and Minnesota have enacted basic health programs, which is an option under the Affordable Care Act. These two states did that early after the implementation of the ACA. Not listed here, more than a dozen states have passed reinsurance proposals through 1332 waivers. Next slide. So I'm going to present to you the results of our analyses. The proposals we've analyzed are grouped into three broad categories. The first set are three proposals that enrich or enhance premium tax credits in the marketplace. The second group are proposals that enhance premium tax credits and combine that with increased subsidies to reduce cost sharing and out-of-pocket payments. And then the third group is the basic health program, and I'll also mention reinsurance there. Next slide. So the first group are three proposals, and Mr. Estrada has done a very nice job of explaining how these percentage of income caps work in the marketplace to reduce premium payments. So this slide is, this shows the complete schedule under current law, and then the schedule for three proposals: enhanced premium assistance 1, which reduces premium payments a little bit; enhanced premium assistance 2, which reduces monthly premium payments even more; and then enhanced premium assistance 3. But to explain them in greater detail, I'd like to go to the next slide and use the more salient example of a family of 2 adults, like the example you saw in Abuko's slides. So if we start with, let's say, the third row here, a family of 2 that has household income equal to, let's say, 275% of the federal poverty line. That means their annual income is $47,410 per year. And under current law, they pay premiums that add up to $4,276 the overall 12 months. Under the enhanced premium assistance proposal, the first proposal, those would be reduced from a little over $4,000 to $3,667 a year. Under the second proposal, enhanced premium assistance 2, those premium payments would be reduced further to $3,425 a year. And then under the third proposal, which is the most generous here, those premium payments would be reduced to $2,941 per year. That's for a family at 275%. And you can see on this table how premium payments fall at these 5 levels of household income. Okay, next slide. So here are the results, the key results in a nutshell. Under the first proposal, Enhanced Premium Assistance 1, the proposal results in 11,000 New Mexican residents gaining coverage and moving into the marketplace for the most part. This would have state costs, of course. It would cost $14 million, we estimate, for the state of New Mexico to implement this policy. The Enhanced Premium Assistance Policy number 2, which is more generous, would lead to 14,000 additional insured people in New Mexico and would cost the state $31 million. Similarly, Enhanced Premium Assistance Proposal number 3 would lead to an increase in 18,000 insured people and would cost the state $52 million. Before I go on, what's not covered here are some other effects. As Abuko mentioned, these enriched premium assistance program that would also affect the people who are currently enrolled in the marketplace receiving subsidies. And we estimate there are about 35,000 people in the marketplace in 2020. And many of them, not all of them, will receive assistance under these proposals as well. Okay, next slide. In the second group of proposals, we're combining the enhanced premium tax credits that you just saw with additional subsidies that reduce cost sharing requirements. Next slide. And here is the schedule showing the actuarial value of standard coverage provided for eligible enrollees under current law and under the proposed enhanced state assistance. And echoing what Abuko has recently reviewed with you, you can see that people below 150% of the federal poverty line, in the first row of this table, currently receive a plan that has about 94% actuarial value, and that would not change under this proposal. However, in the lower rows, people would receive more generous coverage. So if we jump to the third row, where people have household income between 200 and 250% of poverty, they currently are eligible for a plan that gives them 73% actuarial value. Under this proposal, that would jump to 87% actuarial value and would have a substantial effect in reducing, let's say, co-pays required to visit a doctor, co-pays for drugs, deductibles, and the out-of-pocket max. And similarly down the row.
Mr. Chair, can I ask just a clarifying question?
Absolutely, yeah, go ahead.
Okay, I just want to make sure that what we're talking about in these proposals is not just premium enhancement, but also out-of-pocket enhancement. Is that right?
That's correct.
Okay.
This is what I call the second group of proposals, combine both premium tax credits and enhanced cost sharing assistance. And when I say cost sharing, I'm referring to the costs associated with using physicians, going to the hospital, purchasing drugs, and so forth.
Okay, so the first thing you talked about was just premium assistance. This model does both.
Correct.
Got it. Thank you.
Okay, next slide. So here are the results of these three proposals. These are enhanced premium tax credits plus cost sharing subsidies, enhanced cost sharing subsidies. There are three versions of this set of proposals. Under the first version, we would see 20,000 additional insured people in New Mexico, and it would cost the state about $26 million. Under the second proposal, which is more generous, we would see 22,000 additional insured people, and it would cost the state $45 million. Under the third version of this set of proposals, we'd see 23,000 additional insured people, and it would cost the state $68 million. And as I said before, these enriched subsidies, enhanced subsidies, would affect many more than just the 20,000 or 23,000 people listed here. They would also benefit the 35,000 people already enrolled in the marketplace and receiving subsidies. Okay, next slide. Here are the first two groups of proposals shown together, just so you can see them side by side. And I will actually revisit this at the end of my talk. But here are the six proposals showing the increases in the number of insured people and the additional costs to the state, ranging from okay, we'll continue in the interest of time. Let's keep going. The last group of proposals I want to talk about are the basic health program and reinsurance. So the basic health program, as Abuko has already mentioned, is somewhat similar to extending Medicaid, the Medicaid expansion, from 138% of the federal poverty line as it is today, extending it further up to 200% of the federal poverty line for adults who are eligible for premium tax credits in the marketplace. To do this, the state would contract with private managed care organizations. The benefits under this program would have to be at least as generous as marketplace coverage, and possibly more generous. The state is flexible on that, would have flexibility. And out-of-pocket costs to households when they see a doctor or purchase a drug or use some other service would have to be lower than marketplace costs. In order to implement this option under the Affordable Care Act, the federal government allows this. They would pay only 95% of what they would have paid in premium tax credits for those same enrollees in the marketplace. So in order to implement this program and save money, the state would want to likely negotiate lower provider payment rates in order to afford this program. There is a caveat to this program. It substantially reduces the number of people enrolled in the marketplace and could therefore lead to fewer participating insurers in the marketplace and less competition. In the state of New Mexico, we estimate that a basic health program would reduce enrollment by over 40% in the marketplace. We have found that the basic health program works best in states who have very high marketplace premiums, such as New York, and those without Medicaid or managed care organizations already participating in the marketplace. New Mexico does not fall into that category, so it may not be the best plan for New Mexico, but that, of course, is up to you. Next slide. Reinsurance. I'm not going to show the results here. We did analyze 2 reinsurance options, one that offered 10 million reinsurance dollars and one that offered 25 million in reinsurance dollars. We did these policies on top of enhanced premium tax credits. So reinsurance is like giving insurance to the insurance companies. You can think of it that way, and it results in lower premiums. In this case, neither option increased the coverage noticeably beyond what was already achieved through those first 3 set of proposals. Both options would increase state costs beyond the enhanced subsidies. And then there's a caveat to consider. Reinsurance can be effective at lowering total premiums, and that applies that most benefits people who are over 400% of the federal poverty line. It has the sort of surprising effect of occasionally reducing subsidies for those below 400% of the federal poverty line because of the way premium tax credits are calculated. Okay, next slide, and I'm going to wrap up. Okay, next slide. I'm showing here, just for your reference, all 7 of the reform options that Urban Institute modeled for New Mexico. These show the increases in insurance coverage across all 7 proposals. You can see the basic health program did not have a large effect. That's because it's targeted at people below 200% of poverty. And then the very last slide shows in millions of dollars the costs to the state associated with each of these 7 reforms. And that concludes my presentation. I'm happy to join in answering any questions you may have.
And Mr. Chair, members of the committee, I'm going to switch my screen so that way I can close out the presentation with a few additional slides, if that's okay.
Yes, go ahead.
Thank you. So just bear with me here. Can you all still see my slides?
Yes, we can see.
All right. Thank you, Mr. Chair, members of the committee. I know that's a lot of information to take in all at once. And so I just thought it'd be helpful to ground you in taking a look at a comparison of what all of the options look like together side by side, and then take you through a few real world examples of what some of this impact might look like for your constituents. And so as you see here in this table, we looked at a variety of different options to address coverage affordability and to boost enrollment. And all of the options are successful in doing that, ranging from ensuring anywhere from 11,000 to 23,000 more New Mexicans. But as the Urban Institute mentioned, those aren't the only New Mexicans who would benefit from these options being implemented in New Mexico. We would also make coverage affordable for the New Mexicans who already receive coverage through the marketplace, and we would have some indirect benefits on lowering the costs of coverage for unsubsidized individuals in the marketplace as well. And so we really have the opportunity to impact anywhere from 79,000 to 94,000 New Mexicans by implementing one of these options and really improving their affordability. And so the fourth column there on average annual savings per marketplace subsidized New Mexicans is there to show you the potential impact that we could have on an annual basis in terms of savings for New Mexicans who are low income, but would qualify for subsidies in the marketplace. And so let me just take you down.
$1 million, over $1 million per person.
Let me just take you down there to. I'm hearing some background noise a little bit.
Representative Gail Armstrong, I think you're not muted. No, good.
Thank you, Mr. Chair, members of the committee. If we take a look at let's say the EP plus CSA2 line, which stands for the option that would both enhance premium assistance and layer on cost sharing assistance for individuals. And the second option, that would cover 22,000 more individuals, potentially impacting 92,000 New Mexicans. And we would lower costs of healthcare premiums and out-of-pocket costs on average for those subsidized individuals by about 35%, or over $1,100 per year. And then when we're talking about unsubsidized individuals, because we're boosting enrollment, we're making the risk pool larger and a little bit healthier, we would also see a decrease of 17% for unsubsidized individuals, which would roughly translate to about $698 per year saved for those individuals. And then the Urban Institute went through the state general fund costs, and so I won't take you through all of that. But the final two columns take a look at federal premium tax credits in New Mexico that would be spent under one of these options. And so in New Mexico, it's helpful to know that currently the federal government spends $152 million in premium tax credits to help individuals better afford coverage. All of these options that we could implement in New Mexico would increase the federal spending in New Mexico, further helping to improve affordability for New Mexicans across the board. And so as you see there, we could see increases anywhere from $7 million to $40 million in additional federal spending on tax credits. The only one that would see A decrease in spending is the basic health plan, which, as Urban Institute mentioned, is because we would receive more of like a block grant of 95% of the current federal spending to help implement that program. But overall, all of the programs otherwise would increase federal spending in New Mexico. And so, Mr. Chair, members of the committee, we're still digging into the options and the analysis that were provided by the Urban Institute. But just in taking a quick glance, it really does look like that some of the most effective options in the analysis for meeting the goals of improving affordability and boosting enrollment are those scenarios where we're talking about enhancing premium assistance or enhancing both premium assistance and cost-sharing assistance. In terms of the basic health program, that's something that, again, at first glance, looks like it may not be the best fit for New Mexico at this time. Fewer New Mexicans would feel direct investment in their affordability under their program. We would also potentially see, much lower provider reimbursement rates, which is concerning at any time, but certainly during the pandemic. And we would also be concerned about reducing the exchange participation at a membership level of transitioning some of the individuals who are currently in the marketplace away from the marketplace and into the basic health plan. And we'd also would be concerned that that smaller insurance marketplace that is left over might see fewer insurers who are willing to participate in New Mexico. And so, Mr. Chair, members of the committee, I wanted to take you back to the Ezekiel and Sofia Flores family, as well as Nia, to really show you a little bit about what a real world impact could look like if we implemented some of these options here in New Mexico. And so, if you remember, under the current Affordable Care Act, the Flores family would have about a $611 premium in total. The federal government would pay roughly $478 per month in a federal tax credit. And then the family would be left over with $133 per month to pay in their monthly premium. In terms of their cost sharing, they would have an out-of-pocket maximum of roughly $5,400 per year and a deductible of $1,500. Again, this is simply a potential example of the lowest cost silver plan in New Mexico. Like I mentioned earlier, insurers compete in these areas, and so there might be some varying cost sharing values that you would see in plans. But I wanted to give you a real world dollar example of what this could look like for this family under the current law. Now I want to take you through what this would potentially look like for a family if New Mexico were to implement one of the options. And so in terms of the Flores family, let's say New Mexico decided to implement just the enhanced premium assistance option number 2. And so this is the option that provides a little bit more subsidies than the lowest option, and would sort of provide a middle level generosity to New Mexicans in terms of their premium affordability. So the family would still have that total $611 per month premium. The federal government would still pay a tax credit of around $478 per month. But in New Mexico, we would say, we're going to split the difference with the family, and we're going to kick in some state-funded assistance to help lower your costs. And so, whereas under the Affordable Care Act, the family was required to pay about 5.3% of their income, we'd say, for this family, under this option, we're going to require you to pay no more than 3% of your annual income. And that has the effect of lowering their monthly premium from $133 per month to $75 per month. And so nearly cutting it in half for this family. Because this option focuses on premium assistance, we wouldn't do anything to the cost sharing assistance under this option. And so for this family, cost sharing assistance would remain the same as it currently is under the Affordable Care Act. But let's say we wanted to do both, and we wanted to enhance premium assistance as well as cost sharing assistance under the Affordable Care Act. Again, assuming that we're doing the middle generosity of enhanced premium assistance, the family would have that $75 per month premium, which is roughly half of what they were paying before. But we would also tackle their costs on the back end when they're paying for services with providers. And so again, as an example, we could see the family go from an out-of-pocket maximum of, say, $5,400 per year to $3,000 per year. Again, nearly cutting their out-of-pocket maximum in half, and a deductible of around $1,500 per year to one of $0 per year, and potentially $0 copays for things like primary care visits and generic prescriptions. Again, this is just an example. There would be varying degrees of these values for families and individuals, but this just shows you a really great example of how we could improve affordability for New Mexicans. And I think it's a great example of being able to tackle what you all have been talking about regarding the cliff effect as well. And so under these options where we're tackling premium assistance for New Mexicans, we're saying, when somebody makes $1 more than the Medicaid threshold, they shouldn't have to go from paying, $0 per month to now paying $50 per month for their coverage and having, high copays and deductibles. Under one of these options, we would be making that cliff into more of a ramp for New Mexicans. So that way, based on their income, they could phase up to a cost level for their monthly premium that just makes more sense for their family budget. And then if we were to layer cost sharing assistance, as we're doing here in this option, we're going to also tackle their affordability when they're getting services, lowering their copays, lowering their deductibles, and lowering their co-insurance. And so, Mr. Chair, that's what it would look like for families who are, low or middle income in New Mexico. I want to also revisit Nia, who's, a higher income individual in New Mexico. And if you remember, she doesn't qualify for any assistance currently under the Affordable Care Act. And we still wouldn't be making any direct investments in her affordability under any of these options. But we would see some great indirect benefits by boosting enrollment and improving the insurance risk pool. And so if we're continuing with the same example of saying we're going to enhance premium assistance and cost sharing assistance in New Mexico at the middle generosity level, or option 2, it's estimated that unsubsidized premiums for a silver plan would decrease by an average of 16.9%. That means Nia could see her monthly premium go down by roughly $55, or from $326 per month to $271 per month, which is pretty significant when we're not making any direct investments into her affordability, but she's still seeing a decrease in her premiums. And so overall, Mr. Chair and members of the committee, I think what the study shows is that New Mexico has a great set of options to put us in a great position to figure out how to help residents like the Flores family and like Nia, and helping them gain greater access to quality, affordable healthcare coverage. If we were to implement one of the options that I ran you through, the Flores family can now afford to buy coverage And NIA would see benefits of having a decreased monthly premium as well. In addition, by providing the cost-sharing assistance, the Flores family could now get a plan that allows Sophia to get the care that she needs for her asthma treatment without putting a strain on the Flores family budget. And so with that, Mr. Chair and members of the committee, me and the Urban Institute would stand for your questions.
Well, thank you, Jessica and Abuka, for a very information-filled presentation. I've got just one quick question before I turn it over to committee questions. So is the plan then to take this study and to make a recommendation of one approach to the legislature, or are you kind of kicking the ball back to us and asking us to make a decision about which of the many options we thought we would endorse?
Mr. Chair, members of the committee, as I said, we're still digging into the analysis provided by the Urban Institute, but we do want to take a closer look at all of the options, and then if appropriate, at a later time in the interim, we would come back with a recommendation for the legislature to take a look at.
Good. And am I correct in saying there's no federal match or anything? This would all be general fund money other than the additional subsidy for the premiums that would come from the feds?
Mr. Chair, members of the committee, you're correct that there's no match in that traditional sense, but there would be that additional leveraging and spending of federal dollars in New Mexico in terms of federal tax credits.
Okay.
Yeah, even the federal share of premium tax credits would increase when enrollment increased, so they would be paying more. Yeah.
Okay. Well, good. We have one question, one committee member with a question so far. It's Co-Chair Armstrong.
Thank you, Mr. Chair, and thank you, Abuko and Jessica. That was very helpful. And I'll try and be quick, Mr. Chair, because I have 2 points. One, none of this addresses the inability of undocumented immigrants or immigrants who haven't been here long enough and meet all the federal requirements, because those federal requirements preclude them from purchasing in the exchange. So I just want to point that out, and we'll talk more about that, I think, in this afternoon's presentation, but none of this addresses that population that can't get insured. And second, before everyone takes a deep sigh and goes, oh, we don't have any money, how could we possibly do this? When we're looking at such extreme budget shortfalls and just trying to keep Medicaid afloat. And I will just throw out there that we had a proposal last year that I sponsored and that died in the Senate for surtax, because the insurance companies are losing, federal government is no longer taxing or providing imposing a tax on carriers that they were. And the proposal was to pick up roughly equivalent or a little less than that tax as enhanced surtax in the state, and would have generated more than enough money to pay for the most generous of these and the highest enrollment for premium assistance plus cost sharing assistance. So I think as we go forward, Mr. Chair, we're going to have to look at that together, because it's going to be near impossible to have money to do something like this if we don't have a funding source, but we could potentially have a funding source if we did the surtax. So it's not a question, Mr. Chair, I won't take any more time in that regard, just comments for us to keep in mind. Thank you.
Very good, and a terrific suggestion for how this could be funded. That thought had crossed my mind as well. Any other members of the committee with any questions?
Mr. Chairman, can you hear me?
Yes, Representative Anderson.
Yes, I had just a quick question to the presenters. I'm a little unclear about the term premium tax credit, and if I could just have a quick answer to, is that a tax credit against federal liability? How does it work?
Mr. Chair, members of the committee, and so premium tax credit is something that's referred to under the Affordable Care Act as a way that the federal government helps lower the cost for middle to low income individuals. So individuals between 0 and 400% of the federal poverty level. And so what ends up happening in practice is the federal government says, okay, family, you have a required contribution of this much per month to buy the benchmark plan under the Affordable Care Act. But the premium is, say, $611. We're going to cover the difference between what you have to pay and what the full premium is. And that amount in the middle is the premium tax credit that the federal government pays to insurance companies every month to help directly lower the premium cost for New Mexicans.
Therefore, Mr. Chairman, the individual doesn't have to have federal tax liability due, which makes me wonder if I really agree with the idea of it being a tax credit as I understand it. Am I correct sort of in that vague understanding?
Mr. Chair, members of the committee, Representative Anderson, can you clarify sort of what you mean by not having federal tax liability?
Well, a federal tax credit, in my mind, is an offset to your federal tax liability, the taxes you owe. And when we talk about certain low, middle income New Mexicans, I think, well, they may not have federal taxes due, therefore they wouldn't need the credit.
Mr. Chair, Mr. Chair, Representative Anderson, the way that works is if you have a zero tax liability and a $2,000 tax credit, then you get a $2,000 check from the government.
Thank you very much for that, Dr. Scrace. I was pretty sure I was right on that, but I just needed clarification. Thank you, Mr. Chairman.
On that point, Mr. Chair?
Yes, Representative Armstrong.
Just to be clear, this tax credit and how this works does not result in a check that goes to the individual that has to turn around and pay premiums. It is paid directly to the insurance companies. So, but in general, a tax credit for an individual works that way, you'd get a check back. But in this case, it goes directly to the insurance companies. I'm correct on that, right?
That's right. Yeah, I'm sorry. I was talking about in general. Thank you.
Yeah, thank you. Thank you.
Thank you, Mr. Chairman. I've got my question answered.
Great. Thank you, Representative Anderson. Anybody else with a question? Okay, well, I want to thank you. Great progress being made. We look forward to a final report and recommendation when you've done further analysis. Abuko, did you have something else you want to say?
Mr. Chair, members of the committee, before we ended, I did want to turn it back over to Nicole Como, our Medicaid director. She did have a few closing remarks that she'd like to make.
Okay.
Mr. Chair and members of the committee, I'll make this very brief. We just would be remiss if we did not thank our partners at UNM. They worked to help support this study and contributed to it significantly. So we just wanted to thank them for that participation. Didn't want to leave that out.
Great. Thank you, Nicole. Members, before we break for lunch, we did achieve a quorum earlier today, that long sought and rarely accomplished feat. And as a result, we would like to see if we can get the minutes for the last two meetings approved. They were all sent out to you. And so if I could have a motion from a voting member, and then we'll see if there's any opposition. Can I hear a motion?
So moved.
Is there any opposition to adopting the minutes of the last 2 meetings that were sent out to us? Any opposition? Seeing none, we'll consider the minutes to have been approved. Thank you. Now, we're a little behind schedule. The schedule called for us to now have a lunch break and to return at 1. Why don't we return at 1:15? Does that give you enough time to go to your kitchens and raid the icebox? Okay, let's come back at 1:15 for the afternoon session. Thank you all very much. We start with public comment, by the way, at 1:15. Do we have people lined up for public comment?
We do, Mr. Chair.
Which are the ones with the little deals by their name? Which ones are going to make public comment? The exclamation points?
No, I have received some emails, but they're not currently displayed unless they can also raise their hands as well.
What do those exclamation points mean?
That's just the attentiveness of the user.
Oh, now Ruby-Ann has an exclamation point by her name too.
Mr. Chair, this is Representative Cadena. Those exclamation marks are so big brother-ish. They're apparently designed to tell us who's paying attention, but certainly don't do so. And they just measure the ways they're watching our faces. So.
All right, very good.
Please ignore them. Thank you, Mr. Chair. I've been attentive this whole time. I don't know if they put an exclamation next to me. Thank you.
So you do have a list though, Nancy, of who wants to make public comment.
Yes, I have some. However, I don't know if there's more that would like to make public comment.
Okay. Well, we'll find out when we come back from lunch break. 1:15, everybody. Have a hurried but nourishing lunch.
Thank you. Oh.